Live from the beautiful city of Abu Dhabi, welcome to the third day of the 11th International Neonatology Conference. My name is Lane Delumen and I will be your host for today. Over the last 2 days, the conference has been attended by over 3,000 virtual attendees. Such an amazing record, and we thank you very much for your continuous patronage. Today's agenda will be as dynamic and enriching, so please stay on board with us until the final session of the conference. Our rosters of speakers for today are from the international faculty and affiliates from prestigious institutions. We hope our attendees for today are yearning to gain new insights on the latest in infection in neonates, gastrointestinal controversies, and various updates on the development on neonatal medicine. Before we start with the first session of today's agenda, I would like to make a few announcements. We would like to acknowledge and give thanks to the organizations that supported this event: Children's National Hospital of USA, Children's Hospital of Philadelphia, USA, Shesi Pharmaceuticals, Sobi Pharma, Roche, and Prolacta. We urge our attendees to visit the booth of our supporting organizations. If you're interested on their products and services, please feel free to drop a message on the chat box. The representatives for each of these companies are eager to meet up with you virtually. We encourage all our attendees today to participate in the panel discussion by sending your questions to the speakers of each session using the send a message icon on your screens. Certificates of attendance for your participation at the conference will be available 14 days post-conference. An email notification will be sent to your registered email address with instructions on how to do the evaluation and download your certificate. Today's program may be short, yet it's brimming with knowledge, insights, and ideas that can help elevate our practice. Today's agenda will end at 1950. Our first session for today is about neonatology in relation to infection. Our speakers for this session are renowned experts in their field, and it will be chaired by none other than the brilliant Dr. Junaid Khan. You may know him very well as he was introduced a couple of times, and he could may be a colleague at your work as well. But let me read his bio once again for the sake of others who are just watching us today. Dr. Junaid is a consultant neonatologist at Sheikh Shakbout Medical City, where he is also the Director of Medical Education and Associate Program Director for Residents. He previously worked at Al Raba Hospital as the Chief of Service for Pediatrics and Neonatal Intensive Care. Dr. Junaid is a visiting faculty in Pakistan and Canada and has presented in many national and international conferences with his vast experience in the field of neonatal and prenatal medicine. Dr. Junaid has a special interest in neonatal nutrition and respirology. Without further ado, I give the floor to Dr. Junaid. Good morning, Doctor. The session is yours.
Everybody, and good afternoon some places, and I think in Australia is good evening. So we reach our last day of our very comprehensive conference, and it's my pleasure to announce that and to say that we have more than 4,000 delegates and more than 2,000 delegates attending at one point of a time, all the time login. So it's a huge success. We get a lot of feedback already about that. One further announcement that the recording of these sessions, these live sessions will be available at the MENA website, and if you download the MENA conference website, the app, and if you just log in with your email, you will get it to review all the live session if you miss any. So this is very important that if you miss any, you can have access to that after the conference. We will announce that when it will be available for viewer. Without further ado, I will start the first session. And it's my honor and pleasure to introduce my senior colleague, my In fact, it's my teacher, Professor Dr. Sajjadur Rahman. He's a consultant neonatologist and clinical director at Al Qasim KSA in Kingdom of Saudi Arabia. He worked in consultant and associate professor of clinical pediatrics Weill Cornell Medical College in Doha. He worked as a co-researcher in many multi-country randomized controlled trial, including the TOBI trial, and it shows his interest in perinatal asphyxia, HIE, and therapeutic hypothermia. He's worked as a lead investigator of MEC, Cool study, and renal MRCT. He's also investigator of Pearl study. He established Qatar first national perinatal registry. He's reviewer and a member of editorial board of number of journals. He's also an examiner of Royal College of Physicians for children in London. He has authored and published number of articles, a book chapter and a book titled Neonatal and Perinatal Mortality, Global Challenges, Risk Factor and Intervention. So with this vast experience, we want Dr. Sajjad to talk about a yet very hot topic, as this is the hottest topic, which is the neonatal perinatal COVID-19. And he will share with us the Saudi experience also. Over to you, Dr. Sajjad, and very welcome.
Assalamu alaikum and good morning, everybody. Thank you, Dr. Junaid, for the introduction. And I think we quickly go to the topic because we have short time. And this is a hot topic indeed, as you have said, managing the newborn babies with COVID-19, something which we never did before, but now we are doing it and gaining new experience about this new disease in newborn babies. Now, this is the COVID-19 virus, and that's what is creating the problem. And without going into further details about the virus itself, we know about that this is a single-stranded RNA virus, and that is the portion which codes for the spike proteins which protrude out of the virus, and this is the portion which we actually need for making vaccines. The spike proteins are very important because these are the areas through which the virus enters into the human cells, into the epithelial cells, using the acetylcysteine CoA E2 receptors. And these receptors are found in almost every tissue of the body. Sorry, angiotensin converting enzyme receptor 2. So these receptors are present in the respiratory system as well as in many other organs, including the placenta. So if the mother's blood has got viruses, theoretically, the virus can cross the placenta and enter into the blood of the baby. So there are three possible ways by which the virus can infect the baby. One is the perinatal transmission, intrauterine transmission, in which the virus can cross the placenta and enter into the fetal circulation and infect the fetus, or it can enter into the amniotic fluid. And that infected amniotic fluid is either inhaled by the baby or ingested by the baby, and that can infect the baby. The second mode of transmission is during delivery, when the baby can be infected by the secretions of the mother, by the blood of the mother, or by the feces of the mother. The third way is the transmission which happens postnatally, immediate postpartum period. It can be either by the respiratory secretions of the mother, or it can be transmitted from the healthcare workers, family members, and other people in the surroundings at the time of delivery or immediately after the delivery. Now, once the baby has been born to a mother, who has got COVID-19, then we have a number of questions. Whether the baby is positive or the baby is negative, and whether the baby needs any treatment or the baby does not need any treatment. So we want to share what we are doing over here and what is our protocol. We have a big maternity hospital with about 12,000 deliveries per year. And we are a center where all kinds of patients, including COVID positive mothers, come for delivery. So we have gained a lot of experience from dealing with these situations. So neonatal COVID-19, luckily the incidence is not very high. Only 1 to 3% of births to COVID positive mothers have been reported in the US, and the data varies from country to country. The important thing is, when did exactly the mother had COVID-19? If she had it in the first 14 days immediately before the delivery, then the incidence is high. But if it is more than 14 days before delivery, then the baby is very less likely to have COVID-19. When the mothers are COVID positive, the incidence of preterm births, low birth weights, and cesarean section and NICU admission is higher as compared to those mothers who did not have COVID positive status. The mode of delivery does not make a difference, and C-section is not indicated simply because of the COVID positive mother. It can be indicated by other reasons associated with the condition at the same time. But COVID-19 per se is not the reason for going for a C-section. Now, once the baby is born to a mother who is COVID positive, then we go for a test. So you have to test the baby with what we call the RT-PCR, which is reverse transcriptase polymerase chain reaction. And the recommendation is either do it 2 tests. One is at the end of 24 hours after birth and other at 48 hours of birth. Or we can do a single test between 24 and 48 hours of birth. And the method we generally use it, either take a nasopharyngeal swab or oropharyngeal swab or a nasal swab itself. Now, once we have done the tests, then we get the result. Either the baby is COVID positive, confirmed by the PCR, or the baby is COVID negative. So if it is negative, then there is no problem. If it is positive, then we have got 2 questions. Is the baby asymptomatic, or if the baby is symptomatic? Now, if the baby is asymptomatic, then again, there is no much worry. It needs isolation precautions till we prove that the baby is negative. No pharmacotherapy is needed. And we repeat the PCR after 1 week. And during that period, we de-isolate. And once 2 PCRs 24 hours apart are negative, we declare the baby COVID negative, and we move on with the normal care of the baby. So they are discharged, and we closely follow them for any respiratory symptoms or any other symptoms which may arise later on. And the basic principle is that a mother who was infected and who has been afebrile for 24 hours without antibiotics and is clinically improving, she is not likely to be contagious 10 days after the onset of symptoms. And therefore, both baby and mother can go home and she can safely take care of her baby. Now, the problem is when the babies are symptomatic. So if they are COVID positive and symptomatic, they should be clinically monitored, and about 12% of these infected babies get severe illness, which requires admission into the NICU. So once they are admitted in the NICU, they are more likely to be preterm babies. And I have said previously, the incidence of premature birth is more in COVID positive mothers as compared to COVID negative mothers. So they get admitted into the NICU because of COVID positivity as well as prematurity. So we follow the strict isolation precautions, and particularly if you have got a negative pressure room, we should be using the negative pressure room, and all infection control precautions and close monitoring for COVID-19 symptoms. Now, the disease itself has got 2 phases. When anybody is infected with the coronavirus, the first phase is the replication of the virus in the body, and the virus titer goes high. And that is dealt with the innate immunity. But then the virus titer starts going down, but at the same time, we have the adaptive immunity, which starts going up and up. And it is this adaptive immunity which can create problems, and it can produce what we call the cytokine storm. And that can make the baby very sick, or any patient very sick with COVID-19. And therefore, we have got to have treatment both against the virus itself, as well as the treatment against the cytokine storm. Now, how do babies present? So, as I said, there are babies who are positive but asymptomatic. Generally reported is 20%, but can be more than 20%. And we actually see a lot more than 20% who are asymptomatic. Fever is the commonest clinical feature in about 15 to 45%. Respiratory symptoms can happen in 40 to 50% of patients, but they can vary from mild respiratory symptoms to severe respiratory symptoms. Some babies present with poor feeding, lethargy, vomiting, and diarrhea. And in fact, we have seen a number of babies whose initial presentation is acute watery diarrhea. And then that stops within 24 to 48 hours, and then they go ahead and develop the respiratory symptoms. Some babies are very sick and go into what we call the multi-system inflammatory syndrome in neonates, MIS-N. Now, time-wise, as we normally classify neonatal sepsis into early neonatal sepsis and late neonatal sepsis, similarly, the neonatal COVID-19 is also separated into early onset neonatal COVID-19, which is between day 2 and day 7 of life, and the late onset neonatal COVID-19, which becomes symptomatic after 7th day of life. Then, according to the severity of the disease, we divide it into mild to moderate cases, in which the babies do not require any oxygen, and there is no evidence of pneumonia. So basically, they do not have any respiratory problems. They mostly have non-respiratory symptomatology. Then severe cases where they develop the respiratory symptoms, and they can actually develop pneumonia and severe respiratory distress. Then there are some babies who are very sick, critically cases. They are in respiratory failure, they are in circulatory failure, they are on high ventilation, they are hypoxic. They sometimes can develop PPHN, they can be on high frequency, nitric oxide, all kind of inotropic supports, and they are the sickest babies we have seen with the COVID-19. Now, how to monitor the cytokine storm? As I said previously, the second phase of the illness is because of the cytokine storm. So there are a few biomarkers which we use to understand whether the patient has cytokine storm or not. The commonest is to test for the ferritin. If the level of ferritin is more than 300 micrograms per liter on the first test, and then it starts doubling within 24 hours, this is an indication of cytokine storm. Or alternatively, if the first seroferritin level is more than 600 micrograms per liter on presentation, and at the same time LDH is more than 250, this is also an indication of a cytokine storm. The people also measure elevated D dimers, serum interleukin, and people also measure a combination of LDH and CRP. But the most common are a combination of ferritin and LDH. The chest X-ray in babies with COVID-19, it shows non-specific capacities in 56% of cases, and there sometimes can be a ground glass appearance, which could sometimes be mixed with what happens in preterm babies because of surfactant deficiency. High-resolution CT scan in neonates is very useful. It's an excellent tool to diagnose and monitor COVID-19 pneumonia. The usual findings are patchy pneumonia, particularly involving the lung periphery. This is the same pattern as we normally find in the adult COVID-19 pneumonia. But the babies can also have some ground glass appearance. In the adult medicine, they use a scoring system, HRCT, severity scoring system. But there is no established scoring system in pediatrics and for neonatal COVID pneumonia. Now, once we have got babies who are symptomatic and on various levels of severity, mild to moderate or severe or critical, then what is the management protocol? So the management includes general supportive care, general intensive care, which we give to any sick newborn babies, and there is a specific management. We generally follow a protocol which is designed by the Ministry of Health, by all the recent evidence, and they keep on updating it. The latest version we have was updated in August 2021. And we follow the protocol, and it covers patients from newborn babies to adult patients. So there are 4 pillars of management of PCR confirmed symptomatic newborn babies. Supportive care, which is, of course, we provide to any sick newborn babies. Other than that, there is antiviral treatment, immunomodulators, and thromboprophylaxis. In antiviral medication, which we use for 10 days, either we use favipiravir, which is oral, or remdesivir, which is IV. The dose of the favipiravir is 5 milligram per kilogram as loading dose. It's given orally. We generally give a small amount of milk if the baby is NPO. We give 4 or 5 ml of milk just to work as a vehicle with the dose. And the maintenance dose is 2.5 milligram per kilogram per dose twice a day. Remdesivir is the similar one, but it is IV. So sometimes our ID people find it easier to give remdesivir as compared to favipiravir. Immunomodulators, we have usually been using tocilizumab. It's usually given either 1 dose or 2 doses. The dose is 12 milligrams per kilogram and repeated within 24 hours for a maximum of 2 doses. In the literature, there are mentions about the baricitinib, IV immunoglobulins, and systemic and inhaled steroids. We haven't used the first 2, but we do use the steroids. The recommended steroid to start with is hydrocortisone, which we start with 0.5 milligram per kilogram per dose every 12 hours for 10 days. But there are reports in which the people have been using dexamethasone and sometimes prednisolone and methylprednisolone as well. For thromboprophylaxis, there's a standard medication, enoxaparin, which we use as 0.75 milligram per kilogram per dose every 12 hours subcutaneously for a period of 10 days. And of course, we monitor the PT, PTT, INR, and other parameters to see the coagulability and bleeding tendency of the blood. Sometimes we also give them supportive pharmacotherapy in case the baby is taking oral feeds and is okay with the oral folic acid and oral zinc sulfate. It's a non-supportive treatment, non-specific treatment, and non-specific supportive treatment, and there is no evidence whether it works or not, but it's mentioned in the protocols. Now, how to treat the babies depending upon their severity. So mild to moderate cases, we start with the pharmacotherapy. Usually we give inhaled budesonide for any respiratory symptoms, and sometimes only favipiravir. We may or may not give enoxaparin, and usually we do not give enoxaparin for mild to moderate cases. If the patient is severe, has severe symptoms, then of course we give the full protocol. Of course, he's admitted into the NICU, standard pneumonia protocol for a general pneumonia. And in addition to that, we give favipiravir, remdesivir, systemic corticosteroid, hydrocortisone, tocilizumab, and enoxaparin. If the case is critical and looks like the baby has MIS-N, then of course we admit them in the NICU, start with the standard protocol of all the medications which I have mentioned previously, and give full intensive care and supportive care. And usually our approach is a multidisciplinary approach in these cases, where we, along with our ID team, along with the hematologist, along with the pulmonologist, we work as one single team, and on daily basis we discuss the patient and plan for the whole management for that day and for the whole duration. Now I'll just share our experience of 2 cases with the group. One is for the early onset neonatal COVID-19, which appears between day 2 and 7, and the second case is about late onset neonatal COVID-19 after day 7. As I said, early onset COVID-19, the patient can present with nasal congestion, flaring, loss of interest in feeds, and intolerance to feed, and diarrhea. We have seen babies with acute watery diarrhea, and then after 24 hours, the diarrhea starts becoming less, and then they start developing other clinical features, including the severe respiratory symptoms and circulatory failure. So this first case was a preterm 33 plus 3 days with a birth weight of 1.6 kg. His mother was COVID positive at the time of birth, and baby was COVID positive at 24 hours after birth. So in the first 48 hours, he went through the routine RDS prematurity with good response to surfactant, and then he started going to non-invasive ventilation. And then on day 3, again, he started worsening and then required increasing respiratory support. There was no response to an additional dose of surfactant, and it looked as if the baby has pneumonia on the X-ray. So we started him on the COVID-19 protocol, and then we started having his serial swabs. Of course, these serial swabs were taken later on, but they remained positive on day 1, as I mentioned previously, on day 6, day 13, day 20, and the first negative swab which we got was on day 27. So this is the constant pattern. These babies, once they become COVID swab positive, they remain positive for 3 to 4 weeks, and then they become negative. This is the HRCT on day 4, pneumonic consolidation peripherally in posterior basal segments bilaterally and diffuse brown glass appearance. These are the patterns of CRP. It started coming down, and serum ferritin and serum LDH, as we said, we monitored. It initially went up and then started coming down. The same is with the LDH. So he started going up with his cytokine storm and was sick at that time and was on high ventilation. So this is the course in the hospital. Day 7, he had watery diarrhea for 24 hours. Day 7 to 24, he had very difficult ventilative course, was in 100% oxygen, high frequency nitric oxide, and developed tension pneumothorax twice. On day 12, we did an echo, and there was mild pulmonary hypertension. And from day 25 onwards, we started gradually weaning him, and ultimately he went to non-invasive ventilation. So it was a quite prolonged period of respiratory support. And on day 68 of life, we managed to bring the baby down to room air and full feeding. Head ultrasound was normal. There was no ROP, and he was discharged on. And this is the baby who came 3 weeks after the discharge, completely normal, feeding and growing, and no respiratory symptoms, and looked developmentally appropriate for the age. The second is a case of late onset neonatal COVID. And again, these babies have mostly the respiratory symptoms. They can have apnea, respiratory distress, and can have feeding intolerance. The diarrhea is not as common in these babies as was in the early one, but we did see babies who have got diarrhea even in the late onset neonatal COVID. So this is again a 33-weeker with a birth weight of 1.6 kg. Both mother and father were positive at the time of delivery, and the baby was admitted in the NICU because of prematurity and low birth weight. Had initial surfactant deficiency RDS, which resolved very quickly, and within 48 hours, he was went to non-invasive ventilation. On day 5, he developed watery diarrhea, which continued for 2 days and then resolved on its own. But from day 7 onwards, he started having increasing respiratory distress and went back on full ventilation, initially on the SIPPV mode and then high frequency, 100% oxygen. And we did try 1 dose of surfactant, but there was no response. He developed PPHN on the echo. And when we started nitric oxide, it had an excellent response. And then we started him on full COVID-19 protocol. This was the X-ray, and this is the high-resolution CT scan on day 10 of life with bilateral patchy diffuse ground glass opacities. And these are the serum markers, serum D-dimer, ferritin, and LDH, and we can see that they started coming down as we went on with the treatment. So these markers can serve both as a mark for the severity of the disease as well as for the prognosis and the improvement in the condition of the baby. This is the NICU course of the baby. He remained COVID positive on day 1 day 14 and day 21, and the first negative test came on day 31. So we weekly do their COVID tests. And as I said previously, to our experience, they remain positive for 3 to 4 weeks, and after that, they become negative. So on day 14, he was weaned back to SIPPV, and on day 16, he was extubated to NIV, and then by day 18, went on to room air and 4 weeks. Unfortunately, this baby had bilateral PVL on the ultrasound, which was on day 33 of life. And we still don't know whether this PVL is causally related with the COVID-19 itself or not. Or it's simply because of the hypoxic respiratory failure this baby was in at the time he developed COVID pneumonia. We did confirm this with the MRI as well. This baby was discharged home on day 61, and we have yet to see him again in the follow-up clinic. Now, MIS-C, this is the most severe form in children, multisystem inflammatory syndrome in children, MIS-C. It's a novel condition following COVID-19 infection in children, and it is characterized by fever, elevated inflammatory markers, and high levels of both pro and anti-inflammatory cytokines. The reported median age of children with MIS-C is between 5 and 9 years. And there is a criteria to diagnose MIS-C. There is a criteria by the CDC. There are 4 items of criteria. And there's a criteria by the WSC with 6 items in the criteria. And all 4 criteria in CDC must be met, or if you're using the WHO criteria or 6 criteria must be met. So I haven't put that in criteria over here because of the shortness of the presentation. But in practical terms, the same criteria applies to the newborn babies. MIS-N is the multisystem inflammatory syndrome in neonates. It has been reported in the literature, though it's much rarer than the symptomatic COVID-19 otherwise. The diagnostic criteria for MIS-C and MIS-N is the same, whether we use the WHO criteria or we use the CDC criteria. These are the usual clinical features of multisystem inflammatory syndrome in neonates, MIS-N. There's hypoxemia with pulmonary infiltrates, and they can develop pulmonary hypertension. As I mentioned, in both of our cases, they both had hypoxic respiratory failure. They required high frequency oscillation, they required nitric oxide, and they did respond to that as well. They were always in 100% oxygen in the beginning, and of course, when they improved, they got better. And one of the babies, as I have mentioned, was also in severe circulatory failure, requiring full inotropic support. And there can be a number of other symptoms, but the respiratory failure and circulatory failure is the most prominent feature of this condition. Now, what is the long-term impact of neonatal COVID-19? They can have long-term effects of hypoxemia. So we haven't had yet enough number of babies to follow them for a long period of time. The only one baby I showed you is the one who came after discharge, and that looks okay. But the other baby, as I have shown you, has bilateral PVL. So we are expecting quite a difficult course in the post-discharge period for that baby, but we have yet to see and follow. So this is an area where we'll need to learn over the next few years when these babies become bigger and grow, and we need to assess them in the developmental clinic and come up with what happens to the long-term effects of COVID-19 and hypoxemia. They also have a predisposition to childhood asthma. They can become chronic virus carriers. They can have vascular effects because of microthrombosis in their blood vessels, and they can have thromboembolic effects. So long-term follow-up of exposed neonates to assess the respiratory, cardiovascular, and neurodevelopmental outcome is warranted. And this is what we'll probably be doing in the next 3 to 5 years when these babies will keep on coming in our follow-up clinic. And I think that was the last slide. Thank you very much for giving me the opportunity to present on COVID-19 in newborn babies. Thank you very much.
Thanks a lot, Dr. Sajjad. This is a really nice and very simple presentation you gave us for the very complex diseases. So I mean, we learned a lot, and definitely we have a lot of questions in the panel discussion. So please stay until the end of the session. It's my pleasure to introduce yet another very esteemed speaker, Dr. Richard Poland, and he's again teacher and teacher of the teacher, winner of Teacher of the Teacher Award. Dr. Poland is the professor of pediatrics at Columbia University College of Physician and Surgeon at New York, Columbia Presbyterian. He's MD degree earned his MD degree from Temple University. His associate pediatrician, Children's Hospital in 75 to 77. He was named outstanding pediatric attending for 76 to 77. He is the recipient of multiple awards. He published over 200 original papers, 20 books, including the famous one, Fetal and Neonatal Physiology, Workbook in Practical Neonatology, and Pediatric Secrets and Fetal and Neonatal Secrets. And more than 200 abstracts. Dr. Poland is the chair of the NICIG Neonatal Research Network Executive Steering Committee, and he is the immediate past chair of the subboard of the Neonatal Perinatal Medicine. So it's my pleasure to welcome Dr. Richard Poland, and he is going to update us about yet another controversial topic, which is remain have a lot of controversies, the neonatal sepsis. So an update by Dr. Richard Poland. Over to you, Dr. Poland.
Hello, everybody. This is Rich Poland speaking to you from New York City at Columbia University. And today I'm going to be speaking about one of my favorite topics in neonatology, and that is early on sepsis. And I want to bring you greetings from my hospital, which is called the Morgan Stanley Children's Hospital of New York. It's the largest freestanding children's hospital in New York City. We have a NICU that has an average census of about 85 babies, and we're the only NICU that I'm aware of that has a specialized unit for neonates with congenital heart disease. I think we're known for many things, but one is that we have some of the best looking doctors and nurses. And I think if you look at them, it may look familiar to you, but you have to admit it's a very good looking bunch. Sepsis is a worldwide problem. And these are data, both adult and pediatric data, from a review article by Rudd et al. That was published last year, looking at mortality around the world. And the top upper graph looks at various countries, and looks at the incidence of sepsis per 100,000. And the bottom graph is percentage of all deaths related to sepsis. And you see the darker colors on the screen, a lot of South America, Central America, Sub-Saharan Africa, certainly parts of Asia, and perhaps part of the Middle East, where the incidence of sepsis is highest. Again, this is adult and pediatric data, and the percentage of all deaths related to sepsis follow a similar pattern. This is from the same article and looks at three causes of sepsis, or three causes of death in various aged individuals. The red is infection. I'd like you to look at it. It's sort of has two peaks. A peak of sepsis-related mortality early on, and that we know that because babies are most susceptible to sepsis right at the beginning of life, and then a second peak in elderly individuals. When I was a fellow back in the 1970s, taking care of babies with sepsis, we would say is a no-brainer. I'm not sure that translates into other languages, but it was pretty simple. A baby was admitted with sepsis. We took a blood culture, got a CBC, and started the baby on antibiotics. And back in the 1970s, those antibiotics were penicillin and kanamycin, and we treated babies for about 5 days, and just about every baby did well. Now, we did know about the adverse effects of aminoglycosides, both ototoxicity and nephrotoxicity, but we never dreamed that some antibiotics would actually increase mortality has been shown in infants who receive routinely third generation cephalosporins. And this concept of dysbiosis, a change in the microbes in the body, leading to bronchopulmonary dysplasia, necrotizing enterocolitis, and late onset sepsis. And that's the reason we want to try to limit the use of antibiotics in the early neonatal period. The consequences of using antibiotics indiscriminately obviously leads to prolonged hospitalizations. It separates mothers and babies, therefore interferes with breastfeeding and certainly bonding. It can lead to unnecessary procedures, especially IV infiltration is a common risk. And we see probably one baby in my NICU every month or every couple months. It has a significant IV infiltration, and it leads to increased expenses. This is an article, data from an article published in 2014, so about 7 years ago, in which they concluded that the cost to prevent one death by admitting and treating every infant exposed to core amnionitis for 48 hours would be over $10 million. And these are just US data. And you're going to hear me say that core amnionitis, especially for late preterm and term babies, should not be an automatic admit or automatic treatment, but in many hospitals it still is. And the worldwide costs are in the hundreds of millions or even billions of dollars. Let me share with you some numbers. First of all, although we think of sepsis pretty commonly, it's an uncommon disease with an incidence of about 0.5 to 1 per 1,000 live births. If you take the population of late preterm and term babies, if the baby is asymptomatic and well appearing, the risk can be as low as 25,000. That's the reason in that population, if a baby looks well, we tend not to do any further workup. Sepsis workups are far more common in babies who truly have bacteremia, but most babies are for infants who have clinical signs, but truly have non-infectious diseases. The numbers for preterm babies are more ominous. First of all, 3/4 of all deaths from early onset sepsis are in the VLBW babies, so weigh less than 1,500 grams. Just about 90% of VLBWs receive broad spectrum antibiotics for possible sepsis, and prolonged treatment, more than 5 days, is common in the ELBW population. The reason we worry about prolonged treatment or more than 5 days is because of the associated risks of mortality, BPD, late onset sepsis, and necrotizing enterocolitis. So the question as posed in my first slide is how to identify the infant with clinical signs or risk factors who's actually infected. And for us, we would say that's like finding a needle in a haystack. Or the corollary to that is, can we safely decrease antibiotic exposure in newborn infants who perhaps are at lower risk for sepsis? And the opportunities to decrease antibiotic exposure are twofold. First of all, there's healthy appearing babies, late preterm and term babies, with any risk factor infection, and that includes chorioamnionitis or intraamniotic infection. And the second population, who we probably should not treat with antibiotics, are preterm babies with no risk factors for infection, who are born by elective cesarean section, or with ruptured membranes at the time of delivery. And that population is also at very low risk for infection. Now, the two strategies which have been used to decide which babies need antibiotics are use of the sepsis calculator with serial observations, so we don't use one without the other, or serial observations alone without any laboratory testing. Now, as we practice in the NICU, we all like scientific evidence and try to practice in an evidence-based format, but we don't always have the evidence we would like to have. And there's a famous saying by this individual, Carl Sagan, who was an astrophysicist who died a few years ago. He said, absence of evidence is not evidence of absence. So just because we don't have the evidence for every aspect of treatment of sepsis does not mean it's true. And I like to say, less eloquently than Dr. Sagan, evidence is not all it's cracked up to be. Babies can get infected through 4 different pathways. Two infrequent pathways are retrograde infection from the mother's abdominal cavity or infection introduced at the time of amniocentesis. Again, both are quite rare. The two more common pathways are hematogenous dissemination through the placenta, and that's how the so-called torch infections are disseminated to the fetus, or ascending infections from the mother's birth canal into the amniotic cavity, causing a chorioamnionitis or intraamniotic infection. And we know that the establishment of an intraamniotic infection is a key step in the pathway of sepsis. So the risk of sepsis in babies born to mothers who have an intraamniotic infection is dependent on gestational age. If we look at our late preterm and term population, in babies born to women who have clinical intraamniotic infection, still sepsis is quite rare, probably 1% or less. On the other hand, if we start to look at a more immature population of babies born to women with chorioamnionitis or intraamniotic infection, the risk of sepsis is significantly higher. So these are data from the NICHD Neonatal Research Network, looking at babies 22 through 28 weeks gestation, and the three outcomes are histologic chorioamnionitis, clinical chorioamnionitis, and early onset sepsis. So if we look at babies born at the margins of viability, clinical chorioamnionitis is seen in about a quarter of those mothers, and about 1/4 of women with clinical chorioamnionitis will deliver babies with early onset sepsis. That's quite dramatic. If you look at the other extreme of the slide, in the incidence of clinical chorioamnionitis at 28 weeks is only 14%, and only 1 out of 14 babies will develop early onset bacteremia. So the greater the degree of prematurity, the greater the risk of early onset sepsis. And the other interesting thing from the slide is that lots of women have histologic chorioamnionitis. Relatively few women have clinical chorioamnionitis. It tells you that when the pathology report comes back, it says there's inflammation there. It does not mean that it's a pathogen which can cause infection to the baby. The definition of chorioamnionitis or intraamniotic infection, which is the new term, is important because it determines how we manage babies. And there's been a lot of international and national guidelines. I was part of the guidelines in the US, both those from the CDC and Committee of Fetus and Newborn. And the guidelines in 2010, 2011 looked a lot like this. If you have a mother who has suspected chorioamnionitis, get a blood culture test, try to get laboratory testing at 6 to 12 hours of life. But even if the baby looks well, asymptomatic, begin broad spectrum antibiotics. And I made those, in fact, I was the primary author on the publications from the AAP. And for that, I'm ashamed because those are the wrong recommendations. And I'll talk about new recommendations in just a moment. What were the consequences from the CDC guidelines, from the American Academy of Pediatrics, and even the NICE guidelines from the UK? Led to a lot of unnecessary workups for sepsis, prolonged antibiotic therapy solely based on abnormal laboratory values, and increased length of stay for those babies, unnecessary costs, obviously, and invasive procedures, especially when the NICE guidelines were followed. So the question is, can we diagnose an intraamniotic infection in the mother or chorioamnionitis with better precision? And there's 4 ways of defining infection prior to birth. We, as clinicians, we rely upon maternal signs of chorioamnionitis or intraamniotic infection, such as maternal fever, tachycardia in the mother, fetal tachycardia, uterine tenderness, leukocytosis in the mom, or foul-smelling vaginal discharge. I've already talked a little bit about histologic chorio, but usually it doesn't enter into our decision-making because we don't know what the placenta is showing. And remember, histologic chorioamnionitis or intraamniotic infection is 3 times as common as clinical chorioamnionitis in the mother. There are measurements that can be done on amniotic fluid, such as looking for elevated cytokines, not routinely done. And also not routinely done is taking a sample of the amniotic fluid and doing a culture or looking for PCR. All 4 of these are correlated with infection, but the one we rely upon most is maternal signs of intraamniotic infection. The old criteria developed in the early 1990s for clinical choroamnionitis include a maternal temperature of at least 100.4 degrees Fahrenheit, which translates into 38 degrees centigrade, plus at least two of the other findings on this list: maternal tachycardia, fetal tachycardia, an elevated maternal white count more than 15,000, uterine tenderness or foul-smelling amniotic fluid. And the problem with this is that many obstetricians looked at just one thing. They looked at the maternal temperature and said, oh yes, this is a case of intraamniotic infection. Because of that, I organized a workshop at the NIH, which was held in 2015, and we came up with a new definition called III. III stands for intrauterine inflammation and/or infection. And the whole purpose of this was to distinguish women who just had a fever, perhaps from an epidural, who actually had a true choroamnionitis or intraamniotic infection. And we identified three categories: isolated fever, which really was not chorio, or suspected III, or definite III. And I won't go into the exact definitions, except for isolated fever was just a fever greater than 38 degrees centigrade. But the hope was that it would decrease the number of babies who have sepsis workups because of suspicion of maternal infection. Well, he got criticized because of III, but 2 years later, ACOG took almost our exact definition for intraamniotic infection. So they had a category of isolated maternal fever, which is a fever of 38 to 39, a category of suspected intraamniotic infection, which includes a fever greater than 39 or 38 to 39 plus some additional risk factor, such as a high maternal white count or purulent cervical drainage or fetal tachycardia. And then there's a category of confirmed III based on tests done on amniotic fluid. Let me present you a case. This is a case of baby Kim, who was delivered at 37 and 2/7 weeks gestation, so it was an early term gestation, following ruptured membranes for 26 hours. The mother was culture positive for group B streptococcus, a common neonatal pathogen, and received broad spectrum antibiotics, but just 2.5 hours prior to delivery for a temperature of 38. The baby was suctioned and dried by the nurse, placed on CPAP. APGAR scores were pretty good. The respiratory distress went away. CPAP was discontinued. And you see on the slide, this is what baby Kim looked like. And it was obviously a very intelligent looking baby. So how would you manage this infant? You have some choices, and I'm only giving you 3 choices. And I want you, at least in your minds, to pick what you'd select. Supportive care, no antibiotics, testing or cultures, a blood culture and broad spectrum antibiotics, or screening tests or blood culture. And for me, there is only one choice which is correct: supportive care and no antibiotics, testing or cultures. Those of you who follow the old guidelines written by NICE or CDC or the Academy of Pediatrics might choose this, but I think it's outdated, and I hope nobody's doing screening laboratory studies. So when I get a baby admitted and they're worried about sepsis, I ask 2 questions. Is the baby symptomatic or asymptomatic? And is the baby have any risk factors for sepsis or not? So if a baby is admitted to our NICU and they're critically ill and symptomatic, well, again, I'd use the phrase no brainer. We're going to treat a baby who's critically ill no matter what the risk factors are. On the other hand, if the baby is well appearing, but there's still risk factors for sepsis, I think you have some choices. If it's not choroamnionitis and it's not a premature baby, you might just observe the baby. On the other hand, you might want to do some diagnostic testing. And if it's a premature baby and there's maternal suspicion of an intraamniotic infection, you're going to treat that baby with antibiotics. But there's a third category, and the third category are babies who are symptomatic, but there's no risk factors for sepsis. The baby who might be a little bit lethargic or a little bit tachypneic at birth. What I do is observe those babies for 4 to 6 hours and see if they're getting better. Hopefully, it's just a slow transition in many of those babies. But if they're not getting better or if they're getting worse, then I might do some diagnostic testing. If there's any suspicion of sepsis based on clinical signs or diagnostic testing, we're going to treat that baby with antibiotics. If the diagnostic testing is normal and the baby's getting better, then we do not treat that baby. So this is what you see in most textbooks as the risk factors for sepsis. On the left are listed the conditions. On the right is incidence of proven sepsis. So if there's just prolonged rupture of membranes for more than 18 hours, the risk of sepsis in the baby is about 1%. If there are combinations of risk factors, shown at the bottom, such as prolonged rupture of membranes and prematurity, the risk of sepsis is 4 to 6%, or if it's prolonged rupture of membranes and low appetite score, the risk can be 3 to 4%. So risk factors are additive. I want you to look at this one category here, positive colonization with GBS and maternal chorioamnionitis, where the risk in some studies was as high as 20%. And that's the reason the old CDC AAP guidelines said all infants born to mothers with chorioamnionitis need treatment. What we didn't realize when we wrote the guidelines is that these were all symptomatic babies with this high risk of sepsis, and in asymptomatic babies, the risk is much lower. So it was this study in 2011, I can't believe it's 10 years old now, which changed how we approach babies. This is a study by Gabrielle Escobar and Karen Popolo. Dr. Escobar is from the West Coast, Dr. Popolo is from University of Pennsylvania. It was a nested case control study of babies who were at least 34 weeks gestation. The cases included 350 babies who had positive blood cultures, and the controls were about 3 times the number of controls. And what made this study different is instead of using a cutoff value, such as prolonged rupture membrane for 18 hours or maternal fever of 38, all risk factors were treated as continuous variables. Interestingly, in the population, nearly a third of the infants with positive blood cultures were asymptomatic in the first 12 hours of life, but then became symptomatic. This is what the data looked like. And we're looking at a graph, the rate of sepsis according to gestational age. Just to orient you, on the y-axis are cases per 1,000 live births. The dotted line or dashed line indicates the background risk of sepsis in the population, which is about 0.5 per 1,000 live births. The actual data in babies 34 to 42 weeks is shown by the black line, the smoothed out data by the red line. But the lowest risk of sepsis is at term gestation, 38 weeks. It remains low. Post-term babies have a higher risk of sepsis, and those born prematurely have, again, a high risk of sepsis, not surprisingly. And these are the data according to duration of ruptured membranes. Again, the dotted line is the background risk of sepsis in the population. And I said that 18 hours used to be the standard for prolonged ruptured membranes, but even at lesser durations of ruptured membranes, the risk of sepsis goes up, even at 10 to 12 hours, and a longer duration of ruptured membranes, the risk goes up even higher. And this is the risk of sepsis according to highest maternal temperature. I said 100.4 is significant, but the higher the degree of maternal temperature, the greater the risk of early onset sepsis. And again, the dotted line is the background risk of sepsis in the population. So what Dr. Popolo and Dr. Escobar did is they created an algorithm based on these 6 risk factors: the gestational age of the baby in weeks and days, the highest maternal temperature, duration of rupture membranes, the mother's status for group E. streptococcus, was it positive, negative, or uncertain, the maternal treatment, was it GBS specific or broad spectrum like ampicillin and gentamicin, and was it given at least 4 hours prior to delivery. And if we take our case of baby Kim I showed you sooner, these are the numbers I took away. It was a late-term delivery. Mother had a low-grade maternal fever. Membranes were ruptured for 26 hours. She was positive for group E. streptococcus and given ampicillin and gentamicin. And antibiotics were given 2.0 to 3.9 hours prior to delivery. The risk of sepsis, according to the sepsis calculator, was 1.61 per 1,000 live births. If in your population, the background risk is about 0.5, you say, well, that's a baby about 3 times the risk of sepsis. This is a baby I want to observe quickly or more closely and get some laboratory studies on. Well, Dr. Escobar and Dr. Popola went on and said, okay, we know about the risk of sepsis when we have maternal risk factors. Can we now incorporate the baby's clinical signs? And they went and looked at the same babies in the same population and said some babies are well appearing, some babies are mildly ill, have an equivocal presentation, or some babies are dramatically ill. And they did what is a form of Bayesian analysis. They took the pretest probability of sepsis based on historical data I just showed you. They then looked at the baby's clinical presentation, again, well appearing, equivocal, or sick, and they came up with a new risk of sepsis, which they called posterior probability. So taking the same risk factors from baby Kim, if the baby was well appearing with the same risk factors, the risk of sepsis would actually only be 0.66 per thousand live births, and that's a baby would be admitted to the Well Newborn Nursery and do nothing else. On the other hand, if the baby were symptomatic, and they define symptomatic or equivocal presentation very precisely, the risk of sepsis goes up to 8, and that's a baby you probably want to give antibiotics and get a blood culture from. And then if the baby were really sick, the risk of sepsis in the same baby with the same historical risk factors will go up to 33. Again, treatment with antibiotics would be appropriate. You can find, I'm sure you know the sepsis calculator, by putting in Google a sepsis calculator, which allows you to use the same algorithm. So it seems to me there's 3 main management controversies. One is this early onset sepsis occur in babies with risk factors who appear well at birth. I've already said that is true. The suspected intra-amniotic infection in mother mandate treatment of all newborn babies? And the answer is no. You'll hear me say in a moment, if the baby is at least a late preterm baby and well appearing, that's a baby who may need observation but not treatment. And how effective is just watching the baby closely? And how does it compare with the sepsis calculator? In an asymptomatic baby where there are risk factors for sepsis, the risk of sepsis is reduced by 60 to 70%, but it is not zero. And I'm really speaking about the term and late preterm babies. It is not zero. This is I think, a really cool study done by Wortham with collaborators from the NICHD Research Network. It was a retrospective study of 232 symptomatic and asymptomatic babies, all with positive blood cultures or CSF cultures, born to women who actually had chorioamnionitis or intra-amniotic infection. About half of these mothers had both clinical and histologic chorioamnionitis. The rest had a combination of histologic or clinical chorioamnionitis. But the lessons were twofold. Virtually every preterm baby with a positive blood culture was symptomatic. But only 3/4 of the term babies were symptomatic at birth, and 5 term babies developed symptoms a little bit later on. But the second message I think was important. All infants who died were symptomatic within 6 hours of birth. That tells you your early physical examination is very important in predicting which babies are likely to have mortality. And finally, I'm going to summarize the most recent recommendations, I think from December 2018, so it's about 2 years ago now, from the American Academy of Pediatrics, Medium Fetus and Newborn, in babies who are more than 35 weeks gestation. And the preamble for the recommendation is, first of all, important to realize no method is perfect. You're never going to be able to identify every infant who's at risk for early onset sepsis with precision. Each strategy has pros and cons, merits and limitations. Each strategy must include measures to monitor the baby and minimize the duration of antibiotic therapy. And wherever you're practicing, you should choose a strategy which best fits your local resources. So the first recommendation was called categorical risk assessment. It's very similar to the old AAP NICE guidelines. And I personally don't like it. It used risk factor threshold values to identify a population at increased risk for sepsis. So Risk factors can include any newborn infant is ill appearing, in which they recommended lab testing and empirical antibiotics, or any baby born to mothers with clinical comorbidity, in which they also recommended laboratory testing and empirical antibiotics. And I think, again, as I've already stated, if a baby is asymptomatic late preterm or term, that's an erroneous recommendation. If a mother is colonized with group Streptococcus but received inadequate prophylaxis with a duration of rupture membranes greater than 18 hours, or has a gestation age less than 37 weeks, they would recommend laboratory testing but no antibiotics. And finally, they recommend that infants born to mothers with GBS who receive inadequate prophylaxis but without any other risk factors just undergo observation. And for me, this is a problematic recommendation, and I would recommend not following it. That brings us to the sepsis calculator based on data from hundreds of thousands of babies. And it uses objective data at birth and the evolving condition between 6 and 12 hours of life to put into the sepsis calculator and get an estimate of the clinical risk for sepsis. So blood culture and enhanced observations are recommended if the incidence comes out between 1 per thousand, but is less than 3 per thousand. And if the risk of sepsis based on the sepsis calculator is greater than 3 per thousand, they recommend empirical antibiotic therapy. Does the sepsis calculator reduce antibiotic therapy? No question about it. I think it's had a major impact. And this is a meta-analysis of several studies showing that the use of the sepsis calculator reduces empirical antibiotic therapy. But the sepsis calculator has limitations that are important to know. First of all, it misses a substantial proportion of infants with early onset sepsis, not just a little, but a lot. It'll miss 40% of those babies and still recommends treatment of 200 babies for each case of confirmed sepsis. So it's not very precise. Infants with an equivocal presentation and a calculated score of greater than 1 but less than 3 require a blood culture and serial assessments every 4 hours. I'm not sure that's enough. I'll talk about serial observations in a second, but blood cultures have a poor sensitivity in that setting, and the definition of equivocal presentation is likely to overlap with that of a well-appearing baby who's having a slow physiologic transition, depending on when assessments are made. So serial observation is the alternative, and it's one I like, but it is not easy. Serial observation relies on clinical signs of illness to identify babies with early onset sepsis. Using this approach, regardless of any risk factor, infants who appear ill at birth and those who develop signs that you're concerned about of sepsis are either treated or evaluated by laboratory testing. The gold standard for serial observation, I think, came out of Stanford, and it's this article by Frymore, Moyer, and Bennett, published in Journal of Pediatrics in 2020, and this is how they approach serial observations. All the postpartum nurses are educated about signs of sepsis and the importance of repeated clinical assessments. They have a hospitalist, who's usually a pediatrician, attend all deliveries and assesses the baby. If they're concerned about sepsis, the baby is then treated. A level 2 nursery nurse makes assessments every 30 minutes, so much more frequent than every 4 hours, for the first 2 hours of life, then every 4 hours for the first 24 hours, then every 8 hours. Well-appearing high-risk infants who are more than 35 weeks gestation are admitted directly to the postpartum unit for rooming with the mother, and the frequency of observation is followed. Now, if you look at the data on serial observations, it just looks very similar to the data on a sepsis calculator. These are data from Bill Bennett's group, but using the serial observation approach, the use of ampicillin went down, and the use of C-reactive protein as a marker of sepsis also went down. So here's my conclusions. Babies with clinical signs of sepsis that you're concerned about unquestionably need empiric antibiotic therapy. Asymptomatic late preterm and term babies with risk factors for sepsis, including intra-amniotic infection, can be observed without empiric therapy, or you can decide to use a sepsis calculator. I like the approach of serial observations. There are groups of preterm babies who are very low risk of infection. For example, those delivered from maternal indications who can be managed without antibiotics, no matter what symptoms they're displaying. And the question is, can select group of ELBW babies be managed without receiving antibiotics? And this is a question that we're now studying as part of an NIH-funded trial, of which I'm the principal investigator. So to finish out, the blood culture was negative, and because of unremarkable values, the baby was only treated for 48 hours. As baby Kim grew up, he decided to style and color his hair differently, and eventually became president of the United States, defeating a well-known celebrity. So I showed you a picture of baby Kim. We just put Donald Trump's hair on baby Kim, and he looks like a really welcoming individual. On the other hand, if we take Donald Trump and put him with baby Kim's hair, he looks like a pretty unfriendly individual, which I think he was. So thank you for listening to my lecture. I've enjoyed talking to you. Unfortunately, this is being given at a very early time. But I would be happy to receive email questions or correspondence from you, and I will try to respond very timely, in a very timely fashion. Thank you very much for the invitation, and I enjoyed speaking with you today.
Thank you, Dr. Paulin, and really it's again updated us and what to do. We are trying our best to limit the antibiotic use in all those babies. I will go to the next speaker. Again, it's our professor, Dr. Khalid Haq. He was graduated from in my home city, Karachi, in Pakistan. Is retired from University of London, St. George Medical School as a reader in neonatal medicine. He's a fellow of Royal College of London, Edinburgh, and the College of Pediatric and Child Health. He has been principal regional examiner for Royal College of Pediatrics Child Health. Between 1980 and 1990, he's the chair at the King's Saud University as Riyadh, Saudi Arabia. He published 190 peer-reviewed, most recently Essential of Neonatal Medicines and Protocols in Neonatology as a book, edited 5 books also. Professor Haq has done pioneering research work in immunomodulation and other aspects of the neonatal sepsis. He was one of the principal investigators of the INI's trial. He has published consensus definitions of neonatal bloodstream infections, and that have been adapted universally. Professor Haq continued to supervise and mentor master and PhD students. He's the reviewer of 12 international journals and visiting professor to 4 universities. So I welcome Professor Khalid Haq. He's in California, so we will run his recorded presentation about neonatal bacterial meningitis, an update.
Bismillahirrahmanirrahim. It is good to be with you, and I send you greetings from San Francisco. I'm very grateful to Junaid and the organizing committee to have invited me to talk on neonatal bacterial meningitis and to give an update. I have no conflict of interest and nothing to declare. The objectives of my talk are to present to you a brief epidemiology, discuss risk factors and diagnosis, discuss the pathophysiology on how do bacteria enter the brain, how do they cause neuronal injury, then detail some principles and details of management, complications, outcome, and conclusion. Meningitis is more common in the neonatal period than any other time of life, though the overall incidence is low in high-income countries, both in the early onset sepsis and in the late onset sepsis. But in lower and middle income countries, the incidence of meningitis is about 5 to 9 times higher. This equates to about 153,000 neonatal deaths secondary to meningitis. That is 5% of all global neonatal mortality is due to meningitis. Neonatal meningitis remains an important cause of morbidity, such as deafness, blindness, cerebral palsy, seizures, hydrocephalus, or cognitive impairment. And this morbidity has not changed either in the high-income countries or in the low and middle-income countries. And the reason for this is because the early diagnosis of meningitis remains a challenge, and it is unclear how bacteria cross the blood-brain barrier, or how bacterial entry into the central nervous system results in inflammation, pleocytosis, disruption of the blood-brain barrier, and neuronal injury. William Canto, 21 years ago, in an editorial on pediatric and adolescent medicine, asked a question, neonatal meningitis, do we have a clue? And today, I will try, 21 years later, to try and answer some of these questions. But let's begin with a case. Abdul is a 1.6 kilogram male infant born to a 26-year-old woman after 32 weeks gestation. Membranes were ruptured for more than 18 hours. His mother developed a temperature of 37.8 degrees centigrade, half an hour after initiation of epidural anesthesia. A vaginal culture done at 31 weeks gestation was positive for GBS, and intrapartum penicillin was administered 6 hours prior to delivery. Abdul was delivered by cesarean section. Apgar scores were good at 9 and 9. He was admitted to the NICU because of prematurity, grunting, and tachypnea. Chest X-ray showed fluid in the fissure, suggestive of a diagnosis of transient tachypnea of the newborn. However, due to the prolonged rupture of membranes, maternal fever, the team decides to do a septic screen, but debates whether to do a lumbar puncture or not. The debate is centered around the following: grunting, whether it is due to TTN or sepsis, second due to prolonged rupture of membranes, or is it secondary to intrapartum infection, i.e. chorioamnionitis, versus whether it's the maternal fever is secondary to epidural anesthesia, prematurity, or whether the GBS, what degree of protection did intrapartum prophylaxis provide to Abdul, having been given 6 hours prior to delivery. So what will be your management strategy? Initiate antibiotics following full septic screen, blood culture, full blood count, and lumbar puncture? Or would you initiate antibiotics following blood culture and full blood count, but no lumbar puncture, and do LP only if the blood culture was positive? There are no other signs and symptoms in Abdul, but just like sepsis, the signs and symptoms of meningitis are very vague. The features which we commonly see in adults and older children, body stiffness and neck stiffness, is hardly ever seen in the newborn. But because of the risk factors of prematurity, prolonged rupture of membrane, and maternal fever, and tachypnea, which is also present in about 10% of babies with neonatal meningitis, the team is debating whether to do a lumbar puncture or not. Another way of looking at whether an LP may be indicated or not is to look at the risk ratios. What are the risks of Abdul having a meningitis? Well, the risk factor, he is born at 32 weeks, that increases his chances by 4.6%. And I'll come back to DBS in a minute, but he was born after prolonged rupture of membranes, longer than 18 hours, that increases his risk to by 7%. His weight is 1.6, so it increases his risk by 8%. Similarly, male gender, 2%, and of course, intrapartum fever, prolonged rupture membrane, premature, any one of them, he was premature, that increases his risk by 10%. The GBS, it depends on how florid the GBS is in the birth canal, and therefore the ratio varies from 10% to nearly 25%. So if we were to calculate the risk factors for Abdul having meningitis, they are very high, about 31. So I think it is fair to suggest that he needs a lumbar puncture. But why this debate? Why this uncertainty? The reason is that in high-income countries, the incidence of meningitis is low. Hardly any baby with meningitis is asymptomatic. Most babies are symptomatic. Abdul was not. Asymptomatic with risk factors are present has not been shown to be a major factor in doing lumbar puncture. And intrapartum prophylaxis he has received, and so there's some degree of protection. Obviously, nobody would do an lumbar puncture if the baby Abdul was unstable or had thrombocytopenia. But actually, if you look at what the evidence there is about lumbar puncture, everybody agrees that lumbar puncture should always be done in late onset sepsis and where blood culture is positive. In strongly suspected cases where the meningitis is strongly suspected, lumbar puncture should be included, where the evidence is grade B. Lumbar puncture in early onset sepsis is the controversial issue, and as it was in Abdul's case. In my personal opinion, it should be done. However, a very large survey, about 14,000 neonates done by Patrick in the United States, showed that there was pronounced variation in the way LP was performed. These findings indicated that there was no consensus. Some people did LPs with early onset sepsis, and many did not do LPs, and they suggested that this should be studied further. The other difficulty is, of course, what do you take as normal counts or normal values in the CSF? In a very recent paper, Thompson has shown that the median cell count is about 3 with a range of 2 to 6, whereas many others, previous studies have shown the cell count may be normal up to 20. Similarly, Thompson has shown median protein of 57 milligram per deciliter with a range of 43 to 73, but previous studies have shown up to 104 milligram per deciliter of protein being normal. The glucose about 46, between 41 and 51, and that important is the glucose CSF to serum ratio, and I'll come to that. Well, the team decided to do a lumbar puncture. Unfortunately, the CSF was blood stained, white cell count was 20, neutrophils 40%, protein 100 milligram per deciliter, glucose 21.6 milligrams, serum glucose was 50.4, but no organism seen. So, does Abdul have meningitis? Yes, no, or don't know? One just matter of digression here. A number of colleagues I have known do adjustment calculations when there is blood-stained CSF. They adjust the CSF white blood cell count and red cell count ratios. But as Rachel Greenberg, Lyons, and ourselves have shown very clearly that if you do any of these calculations, whether you do 500 to 1, 1,000 to 1, or use any other ratio, the sensitivity and specificity of such counts is very, very low. And therefore, I personally think it's a totally waste of time trying to calculate these ratios. So the current position about lumbar puncture is this. The protein concentration above 150 or 180 indicate poor prognosis. Glucose concentration should be 70 to 80% of serum levels, and if you want a ratio, it should be more than 0.44. The blood culture actually is only positive in about 38% of cases with meningitis. But the more important thing which I want you to take home is that nearly a quarter of neonates, particularly preterm neonates with meningitis, have normal CSF blood count, normal glucose, and normal protein levels. The cell count is often used as a basic gold standard, and Richard Folin, who spoke earlier, has shown that if there are 15 cells in the CSF, it should probably be considered suspect, and if there are more than 20 cells, it should be considered elevated. Right? So now Abdul has remained asymptomatic, but he's hemodynamically unstable. Cultures are still pending. What other tests may be of value in the diagnosis of bacterial meningitis? There's a large number of tests which have been done and shown to be of some use. But what I do want to point out is one simple test which nearly all of us have facilities to do, but don't do it, is the CSF lactate. It has a high sensitivity of between 88 to 96% and a very high positive specificity of 98 to 100%. If I was to choose what test I would do on a CSF, I would certainly do a white cell count, I'd do protein, I'd do a CSF blood glucose ratio, I'd do a CSF CRP or a lactate. If I was considering GBS, I would do GBS antigen. If my CSF was blood stained, I would do a multiplex PCR because that would give me high degree of specificity to diagnose meningitis. More advanced units and units with a lot of funding are doing so-called omics studies, studying genomics and cytokine arrays, proteomics and metabolomics. But I think even in those, if you read all the literature, the three tests which have been shown to be of great value is 1-glial fibrillary acid protein, C3, because C3, if it is low, it suggests poor prognosis. But once again, lactate has been highlighted as a very good marker of meningitis. If you do an ultrasound in meningitis earlier on, you might find edema, later meningeal thickening, subdural effusion, and much later you would get ventricular dilatation with debris collection and development of hydrocephalus, and much later liquefaction of the cerebral cortex. If you add Doppler to it, initially you will see increased meningeal blood flow, you might see subdural effusion, and then in late stages you will see liquefaction. MRI and CT are hardly ever needed. If it is needed, I would prefer to do an MRI rather than a CT because of radiation. Obviously, microbiology is extremely important, but microbiology and the pathogens differ from country to country and in fact from unit to unit. In the Western world, GBS and E. coli are the most common organisms. In Africa and Asia, it is again E. coli mainly with polysaccharide K1 capsule or Klebsiella. And I recently found a paper from UAE which was talking about neonatal sepsis, not particularly meningitis, but interestingly, they also see more E. coli and Klebsiella. Now, having made the diagnosis of meningitis, once we need to understand why meningitis develops. It needs bacterial host interactions at 7 stages. So initially, there should be colonization, invasion, attachment, inflammation and replication, evasion, survival and progression of infection, brain injury, and progression of inflammation. And I'll discuss each one of them. Colonization. Bacteria ascending from maternal birth canal colonize the skin, nasopharynx, and other parts of the infant, and particularly if there is intra-amniotic infection, i.e. chorioamnionitis, then you would get a fair amount of pathogen entering the amniotic fluid. And so most of the infection a newborn gets in the early onset is ascending infection. Very, very rarely it is from the environment within the first 72 hours. But certainly late onset sepsis, i.e. after 72 hours, it is the environment which is mainly responsible for the pathogens. What about invasion? The bacteria enters penetrates the mucosal barrier, whether it be in the bronchial tissue, in the lungs, in the blood vessels, or in the gut. And what happens is when we put a baby and put an endotracheal tube, we damage the mucosa, and that gives the chance of bacteria to enter the mucosa and enter into circulation. When we put picket lines, venipuncture, or even simple tape, and when we take the tape off, the first epidermal layer of the skin peels off, and that gives an opportunity for organisms to enter. But the most important way the bacteria enter into this circulation is from the gut, where they pass through the tight junctions, which are slightly looser in the newborn, and if they have been stressed or hypoxic, then these tight junctions are even much looser, and so it makes easier for the bacteria to enter the vascular subepithelium. And this is the key step in pathogenesis of meningitis. Once the bacteria have entered in the blood vessels, bacteria need to cross two structural and functional barriers to reach the CNS, the blood-brain barrier, the blood-CSF barrier. And these barriers are different. They are not the same. For example, the blood-brain barrier, the endothelial cells are joined with tight junctions. These endothelial cells have tight junctions that regulate the flow of solutes and that do not allow the bacteria to enter. They also are covered and ensheathed with a basement membrane, once again a secondary protection of not allowing bacteria to enter the blood vessels. And last but not least, the astrocytes have these end or foot processes which also surround the blood vessels. Thus, it is very difficult for bacteria to enter through the blood-brain barrier. However, for the blood-CSF barrier, the story is quite different. Let's just compare the adult, why they don't get so much meningitis compared to the neonate. In the adult, the cells, the endothelial cells in the blood vessels and in the gut mucosa or the lung mucosa are tightly fixed with tight junctions, absolutely tight junctions. Secondly, the proteins are, and there is also adherents which stick these two cells together and thus do not allow the bacteria to cross in between the cells. However, in the newborn and particularly in the preterm, these tight junctions are loose, the tight junctions are weak, and the adherent junction proteins which make these cells stick together are also loose, thus allowing the bacteria from the gut to easily enter into the blood vessels. And this is where in the choroid plexus exactly the same thing happens. The tight junctions are very loose, and the endothelial cells of the choroid plexus are fenestrated, and that's allowing the bacteria to enter the brain and the CSF. How do bacteria then enter other than entering through once they have escaped into the blood vessels? They have three mechanisms by which they enter into the brain and the CSF, which is called transcellular. That means they enter and break the cytoskeleton of the cell. Once they are in the cell, they surround themselves with a capsule so that they are not attacked by the cytoplasm of the endothelial cell. And this then, as the cell moves, the bacteria moves along with the cell. The paracellular is through the tight junctions. The bacteria move. If the junctions are not tight, they escape in between. And here you can see the bacteria crossing where the junctions are not very tight. But the most interesting and important factor is the Trojan horse phenomena, where the bacteria enter into a white cell or a macrophage, remain there and stick to them. And as the white cell and the macrophage enters the circulation, enters the CSF, they are carried along with it. Here's an E. coli on a phagocytic white blood cells sticking in. As the phagocyte moves into the cerebral circulation, the bacteria will move in. So once the bacteria have entered the CNS, they cause inflammation and have to multiply. What do? They create oxidative stress and formation of free radicals, which go on to kill the neuronal cells, secondary to oxidative stress. They also cause mitochondrial failure and the release of metalloproteinases and other toxic fragments, which cause autophagocytosis and cell death. They increase cell death by apoptosis, necrosis, and apoptosis. And what is more important is that they set up a vicious cycle of inflammation by stimulating and activating the astrocyte and the microglia, which release chemokines, cytokines, and this circle keeps going around, it causes more break in the blood-brain barrier. It allows more cells to come in to the CNS. Once it is in the CNS, and the cells are also in the CNS, they alter the cerebral blood flow by causing edema, spasm, and thrombosis, and they increase neuronal cell death due to influx of sodium and calcium into the cells. Activated astrocytes and macrophages directly damage the white matter and neurons, release cytokines, act on the microglia and astrocyte, transforming them into antigen-presenting cells capable of displacing myelin fragments from normal myelin. And these activated macrophages strip the myelin here from axons, affecting normal transmission of nerve impulses, causing diverse motor symptoms like seizures and sensory and autonomic symptoms, which we see in meningitis. But once these bacteria are doing all that, they have to survive, and because they are being attacked by the host defense system. But as I've shown you, organisms are very clever. E. coli forming a capsule, thus it cannot be recognized by the toll-like receptor, so it cannot be attacked. The other is, of course, that there is in the brain and in the CNS, there's localized areas of, it is a localized area of immune deficiency because there is very little secretory IgA and IgG to form antibodies and to fight these bacteria. The other and the only way the newborn can fight the infection in the meninges is through deposition of C3b on the surface of bacteria, which promotes phagocytosis and clearance of bacteria. But of course, the bacteria being very clever, particularly GBS and E. coli, they inhibit the C3 as well. So they actually are much better in surviving than the immune defense system of the newborn. Progression of inflammation is a vicious cycle, as I've shown you, because of the oxidative stress, because of mitochondrial damage, and because of the activation of astrocytes and microglia, which keep on producing more chemokines, cytokines, and breaking the blood-brain barrier. So in summary, the pathogenesis is bacterial invasion, release of toxins, activation of homopoietic cells, bacterial attachment to white cells and endothelium, transendothelial migration of activated cells, crossing the blood-brain and the blood-CSF barrier, release of pro-inflammatory cytokines and chemokines, activation of astrocytes and macrophages, which further release cytokines, metaproteinases, cause hypoxia, and increase in lactate and cell destruction. And this vicious cycle goes round and round and is responsible for brain damage. So, to answer Dr. Kanter's question, yes, we are getting closer to understanding the pathogenesis of neonatal meningitis a little better, but are we any better at managing neonatal meningitis? Our main objectives in the management of meningitis are to reduce the source of bacterial entry into the CSF, kill the organism, reduce or neutralize, eliminate bacterial toxins, and boost the host defenses if we can, and prevent neuronal and white matter damage. Reducing the source of entry, of course, is good hand hygiene, good preventive medicine, prevent prematurity or prolonged rupture of membranes, intrapartum prophylaxis, and some people have shown anti-TNF alpha or interleukin 1 beta may be helpful in preventing infection. We have shown that IgM given early is also preventive in preventing sepsis and in meningitis. Our immediate goal for treatment is to, of course, to sterilize the CSF as quickly as possible, prevent progression of infection, prevent neuronal damage if possible. So the main tool which we have, or the main weapon which we have, are antibiotics, but we have to choose the antibiotics very carefully. We need to choose bactericidal antibiotics. We need to choose antibiotics which achieve high concentration in CSF. And here you can see the CSF serum ratio of antibiotics. And the best we can get is gentamicin, ceftriaxone, cephalosporins, and of course colistin. But we don't really use that. Our base is based on ampicillin cephalosporin and aminoglycoside. In meningitis, the CSF pH changes, and that reduces the effectiveness of aminoglycosides, and that is the reason you need to increase the dose of aminoglycosides to achieve good CSF levels. Protein-bound antibiotics like cephalosporins also have diminished activity, but still maintain a fair good amount in the CSF. Bacteria, if they grow slowly, then the beta-lactams are less effective, and some of the antibiotics are metabolized in the CSF, like imipenems and things, or the hydrophilic antibiotics like vancomycin. This is the reason why we all differ in what antibiotic we choose, but for most purposes, I think ampicillin, cephalosporin, and gentamicin are the drugs of choice. The current consensus, if there is any, is that empiric regimens of penicillin and cefotaxime, or a combination of penicillin, e.g. ampicillin, and aminoglycoside is recommended for initial empiric therapy, but the level of evidence is only C. Gram-negative meningitis should be treated for at least 14 to 21 days. Class of evidence B and C. We use cefotaxime and aminoglycoside. Gram-positive infection should be treated for at least 14 days. Class C evidence. Listeria you treat with ampicillin, and penicillin is equally effective. Coagulase negative, vancomycin, ESBL, meropenem. We very rarely have used, there have been 2 papers on the use of colistin given intraventricularly due to in cases of ventriculitis secondary to meningitis. There is another debate in the management of meningitis as whether to do a repeat lumbar puncture or not. Again, coming back to Rachel Greenberg's paper, she has shown that the time taken for CSF culture to become negative is a median of 4, varies from 2 to 7 days. The time taken for CSF protein to normalize is much later, 8 days, and the range is between 5 and 10 days. Time taken for glucose to normalize is early, within 48 hours, range 1 to 3 days. But the time taken for white cell count to normalize in the CSF takes a much longer period, and the range is 6 to 30 days. So there is very little evidence to suggest that a repeat LP is necessary, unless, of course, the baby is not improving or you're suspecting some other pathogen like fungal meningitis. Most neonates with meningitis develop cerebral edema, which is also vasogenic. It is also cytotoxic. It is osmotic and interstitial because of entry of sodium, and water leads to immediate cell death and swelling and lysis. And entry of calcium into the cell increases apoptosis. So cerebral edema is dangerous, but it occurs in nearly all babies with meningitis. The question is whether, when there is evidence of cerebral edema, should you restrict fluid or not? The evidence there is suggests that there is no advantage in restricting fluid, but certainly one should not be very liberal. If you restrict fluid, you will get hypoglycemia, more acute kidney injury, more polycythemia, more weight loss, and more shock. In my own practice, I don't restrict fluid. I give normal fluid, but I'm not very generous with fluid, and I don't go overboard. You need to correct inappropriate ADH secretion. Dexamethasone has no role, neither has mannitol or glycerol. What about preventing neuronal injury? Well, there is very little evidence to suggest any of the antitoxins, free radical inhibitors, steroids, endothelin antagonists, whether they work or not. There's very little evidence that they work. Anti-TNF is harmful. We need to, our work has shown that reset the cytokine balance, modulate inflammatory coagulation through IgM. That is, as I showed you, the meta-analysis, you need about 7 infants to get benefit. More recent research work is on use of brain-derived neurotropic factors or mesenchymal stem cell, which prevents the release of oxidative stress factors and also allows regeneration of neuronal cells. So that is at the moment experimental, but that's where I think the answers would lie. Of course, we all know complications like seizures occur, and if they last for more than 72 hours, there's a very high chance of morbidity and severe disability. Babies may develop hydrocephalus or brain abscesses. The outcome in less than 5-year-old under 5s and followed in low and middle income countries, as I told you, mortality is high, but there is very high level of 60 to 80% have developmental delay or motor deficit, hearing impairment, epilepsy, or vision impairment. But the numbers are very similar in the developed world, where there is high level of neuromotor disability, about 40%, and seizures about 20%, and learning difficulties about 30% in the high income countries. I started with epidemiology and gave you global figures. Global figures are there are about 300,000 cases of meningitis, of which 27,000 will end up with neurodisability, and I told you 150,000 will die. Of course, we can prevent if we had the opportunity to diagnose meningitis early, give GBS prophylaxis where GBS is common, and of course there are vaccines which we should routinely be using and giving to the babies. So if I'd like to conclude here, the neonatal meningitis remains a devastating disease, incidence and treatment of which has not significantly changed in the past 30 years. Mortality has fallen, currently about 6.6% in developed and 50 to 60% in the developing world. Morbidity has not changed. It remains between 65 to 80%. The improvements in outcome will result from interventions to decrease the incidence of early onset bacterial sepsis, rapid identification of affected infants, better understanding of the mechanism responsible for brain injury, concomitant use of antibiotics and neuroprotective agents. Thank you for your attention. These are my references. I'm quite happy to answer any questions.
Thank you very much, Professor Rad. Really very illustrative and very comprehensive talk about neonatal meningitis. Without further ado, it's my pleasure to introduce or to have Dr. Karen Popolo from the Children's Hospital of Philadelphia. She is the chief section on the newborn pediatric Pennsylvania Hospital. She is graduated from the Tufts University School of Medicine. She did her fellowship in neonatal perinatal medicine in Boston Children, and she is board certified in neonatal perinatal medicine. She got her PhD in medicine and cellular and molecular physiology at Tufts University. She is in editorial board of pediatrics, membership in professional organizations. She is the president of, she's a member of American Academy of Pediatrics and the committee of the fetus and the newborn. She is going to update us about acquired cytomegalovirus infection in the preterm infant, epidemiology and outcomes. To you, Dr. Karen.
Hello, my name is Karen Popolo. I'm a neonatologist at Children's Hospital of Philadelphia in the United States. I appreciate the opportunity to present today at the International Neonatology Conference, and I'll be speaking with you about acquired cytomegalovirus infections in the preterm infant, epidemiology, and outcomes. I have no financial disclosures. The presentation will refer to, but not endorse, the off-label use of ganciclovir for the treatment of postnatal CMV infection in preterm infants. These are our learning objectives today. Cytomegalovirus, or CMV, is a ubiquitous human virus. It's double-stranded herpes virus with numerous strains. Transmission can occur horizontally by direct person-to-person contact, usually via saliva. It can also occur via blood transfusion and organ transplant. And most important to us today, it can be transmitted from mother to infant before, during, or after birth. And after birth, one of the sources of CMV infection is breast milk. As a ubiquitous virus, most adults encounter it in childhood, and many are infected and immune by the time they reach adulthood. The seroprevalence to CMV does vary in different countries across the world, and even within the United States, there is some variation that exists from state to state, by race and ethnicity, and by socioeconomic status. The issue of how CMV is transmitted from mother to newborn was studied in great detail in seminal work done by Stanio and colleagues in the late 1970s. In an important study, this group did serial testing by CMV culture during pregnancy and during the postpartum period from nearly 400 women, testing cervical secretions, urine specimens, and saliva specimens from these women. 278 of the women also contributed breast milk or colostrum samples. And CMV was detected in the milk or colostrum of 38 of these women, or 14% of the cohort. From here, the investigators focused specifically on the role of breast milk in transmitting CMV. They identified 28 women in whom CMV had only been detected in breast milk or colostrum and had not been detected in any cervical, urine, or saliva specimen. Among these 28 women, 19 of them were breastfeeding and 9 of them were formula feeding their infants. The infants were serially tested throughout infancy, and ultimately 11 out of the 19 breastfed infants, or 58%, became CMV positive, and none of the 9 infants who were being bottle fed became CMV positive. The infants were found to be infected with CMV anywhere from 4 weeks to 4 months of age, although there was one outlier at 9 months. Interestingly, the infection rate that was observed in the study was almost exactly the same as the infection rate observed when women had CMV found in cervical secretions at the time of vaginal delivery. In this study that focused on term and otherwise healthy infants, none of them who are identified as being CMV positive became clinically ill. And ultimately, no differences were found in neurodevelopmental outcomes in early childhood, and this included assessments of the children's hearing and vision. On this study, published in the New England Journal of Medicine in 1980, the investigators made this statement: because the infection produces minimal morbidity and leads to chronic shedding of virus into urine and saliva, it must be viewed as a form of natural immunization. And they concluded thus the minimal risk associated with transmission of CMV through breast milk is clearly outweighed by the well-established value of breastfeeding. The topic of our conversation today really comes down to, does this statement apply to preterm infants? Specifically, what about baby G? So baby G was an infant cared for in our NICU here in Philadelphia. Born at 23 and 6/7 weeks with a birth weight of 520 grams, this infant was tested for CMV shortly after birth and was found to be negative. At day 40 after birth, the infant was stable on CPAP support, getting full enteral PG feeding with a combination of fresh and frozen mother's milk. On day 41, the child acutely became ill with a respiratory decompensation and required reintubation. A sepsis evaluation was done. It revealed neutropenia, a new onset thrombocytopenia, and an elevated CRP level. Blood cultures were sent, antibiotics were given, and a urine CMV was sent as well. So I would hazard to say that if I told you that baby G grew Klebsiella pneumonia from those blood cultures, you would know how to treat with antibiotics. You would worry that the infant would now have an increased risk of death or BPD, a prolonged length of stay in the NICU, and you would worry that there'd be an increased risk for neurodevelopmental impairment on the basis of this infection. And you would wonder what lapse in infection prevention had led to this infection. But if I told you the blood cultures were negative and the urine CMV PCR was positive, you would call your ID consult, who would be uncertain as to the value of ganciclovir treatment, which is the antiviral treatment of choice for CMV. You would be uncertain about the potential additional impact of this infection on the infant's risk of death or BPD, risk the length of stay in the NICU, and ultimately the child's neurodevelopmental impairment risk. And you would wonder and maybe doubt whether there was anything you really could have done to prevent this infection. So how do we answer these questions? In the next few slides, I'll review what we do know about the epidemiology of CMV infection among preterm infants. Studies of CMV detection in our babies have benefited from the development of additional methods of CMV detection. The studies that were done in the 1970s were all done by traditional cell culture for virus, the results of which would take up to 3 weeks. Rapid culture methods, which look for the expression of early CMV antigens, are quicker and can give a result in 1 to 2 days. Nucleic acid-based methods of PCR are now in wide use. You can use them on blood, although they have low sensitivity on dry blood spots, urine, or saliva, and they are very sensitive, pretty specific, and detect some cases that are culture negative. Postnatally acquired CMV does need to be distinguished from congenital CMV, which is defined as CMV infection detected at less than 2 weeks of age. And this is usually attributed either to transplacental transmission of the virus or to intrapartum transmission via infected cervical secretions. In the United States, the CHIME study has definitively demonstrated that the incidence of congenital CMV in the overall birth population in the United States is about 0.5% or 1 in 200 live births, and only about 0.5% of those seem to have an expression of illness from the infection. Very low birth weight babies are not different in incidence, although this is a less well-informed area. One NICU in Alabama reported on their experience routinely testing very low birth weight babies for CMV within 2 weeks of birth on admission to their NICU. In this report, 18 out of 4,594 infants, or about 0.4% of them, were found to have congenital infection, not different from the overall birth population. So how do preterm infants acquire postnatal CMV? Well, prior to contemporary blood breaking practices, transfusion was a source of acute CMV infection among preterm infants. With the development of practices that focus on CMV negative donors and on leukoreduction of transfused units, that is the removal of white blood cells, which are often the source of CMV within the transfused product, blood transfusion has largely been eliminated as a source. Yet it was observed that preterm infants still seem to acquire postnatal CMV. A number of centers have done surveillance studies to determine what the etiology of these infections would be. And I highlight one here that was published in 2001 from a German site. In this NICU, infants with birth weight less than 1,500 grams and gestational age less than 32 weeks, all of their mothers had CMV serology obtained shortly after infant admission to the NICU. The infants underwent biweekly CMV tests on their urine, and every couple of weeks among breastfed infants, samples of breast milk were tested as well. Anytime an infant was noted to have acquired CMV infection, the infant was assessed for symptoms with an onset about 1 week prior to the detection to 2 weeks after the detection to determine if the infection was symptomatic or asymptomatic. In this report, CMV was detected in no infants born to seronegative mothers, and in 38% of infants born to seropositive mothers. Of those 38, about half of them were considered to have a symptomatology attributable to the CMV infection. Still, questions have persisted about the relative role of blood transfusion versus breast milk-acquired CMV. Concerns that really should be definitively put to rest by a publication, by a study that was done by Josephson and colleagues in 3 Atlanta, Georgia NICUs and published in 2014. And this study included 462 mothers who gave birth to 539 very low birth weight infants. All of the mothers were tested for CMV antibody after birth, and women who were CMV negative were tested by PCR at infant discharge to ensure that they had not acquired CMV during their infant's care. The infants were tested shortly after birth to rule out congenital CMV, and then at specific intervals and at any time there was a clinical suspicion for infection. What made the study unique is that all of the blood products administered to these infants during their care were tested for CMV by PCR and were also tested by methods to detect any failure of leukoreduction. Finally, breast milk samples from women who were providing breast milk for their infants were also serially tested up to about 6 weeks of infant age. First, I'll report that the blood products had no CMV. Of the 1,038 units tested, all of them were CMV negative, and only one platelet unit had residual white cells detected. This unit had no CMV and was not associated with a CMV infection. So how much CMV infection was there? Of these 462 mothers, 352 of them were CMV positive, the rest were CMV negative. During the course of the study, 29 infants acquired CMV infection. One of those 29 was considered to be a congenital infection, and no cases of CMV occurred among the infants born to seronegative mothers. All 28 infants had been fed breast milk, and CMV was detected in the milk samples in 27 of 28 of these cases. And this study can really be viewed as sort of the definitive evidence that in the setting of modern blood banking practices, very low birth weight babies can acquire CMV. They do not acquire it from blood transfusion, and they do seem to acquire it when fed breast milk from mothers who are infected with CMV at some point in their lives prior to the baby's birth. So what were the outcomes of the CMV infected infants in this study? There were 28 infants again, which represented 6.8% of the at-risk very low birth weight babies in the study. 5 of the cases were considered to be symptomatic. In 3 cases, the infants died. All of them had developed a neck-like illness, and one death, however, was attributed to CMV pneumonitis. One of them had a sepsis-like syndrome but survived. One also survived but developed basal ganglia calcifications that had not been seen on prior imaging. But interestingly, there was no clinical suspicion for the infection in 24 cases, including the congenital case. There are a number of other case series in the literature describing a sepsis-like syndrome attributed to postnatal CMV infection in very low birth weight babies. A particularly disturbing report was one from a center that reported on 5 cases of sepsis-like syndrome attributed to CMV. This apprised 15% of all of the infants born at 23 to 28 weeks at the center over a 2-year period. In this publication in 2010, all of the infants were born at low gestation. All of them acquired presented with a severe sepsis-like picture anywhere from 6 to 8 weeks after delivery. All of them at the time that they presented were on non-invasive respiratory support and full volume feeding. One of the 5 was reported as dying of the infection. One went on to have severe lung disease requiring tracheostomy, and 3 did recover. In investigating these cases, the authors report that CMV viruria and viremia was identified in all cases. Multiple cultures of blood, urine, and CSF for bacterial pathogens were negative, other than one case of Klebsiella. All of these infants had been fed fresh mother's own milk, and CMV was isolated subsequently from each of these mothers' milk. All of these infants in this publication were given ganciclovir with a 1-log reduction in viremia, but with variable clinical improvement. So what overall are the characteristics of preterm postnatal CMV infection? As suggested by the studies that I've highlighted, there tends to be an onset of viruria approximately 6 weeks after birth. And because this primarily impacts very low gestation infants, it tends to occur at an adjusted age of about 33 to 36 weeks gestation. There are multiple reports of these severe cases which present with a sepsis-like illness. But overall, the literature on postnatal CMV is dominated by less severe and often silent disease, identified either by surveillance practices or by the somewhat happenstance identification of thrombocytopenia or abnormal liver function tests. The risk factors for acquired postnatal CMV are dominated by lower gestational age and birth weight. This is a disease primarily of infants born under 28 weeks gestation. Other risk factors include the volume and duration of breast milk feeding, a higher versus lower viral load in the breast milk, and there is some role for CMV-specific antibiotic in breast milk. Obviously, maternal serum antibody as well as antibody in milk is not entirely protective, but higher CMV-specific IgA levels do seem to correlate with lower risk of acquisition, and higher IgG avidity in milk seems to be associated with lower CMV viral load. Investigators at CDC performed a meta-analysis and did population estimates for the overall impact of postnatal CMV on very low birth weight infants. This study was published in Pediatrics in 2013, and it included 17 studies that had been published in the 21st century, predominantly from Europe and North America. The study distinguished the estimated risk of any form of postnatal CMV infection and the risk of sepsis-like syndrome from CMV infection in the study infants, and then translated that to the VLBW population. Interestingly, the risk of any CMV infection was a little bit lower with frozen milk versus fresh milk, but severe sepsis-like syndrome, the point estimates were not different, and I've highlighted that here, perhaps arguing that even at a potentially lower viral load in the milk, the most vulnerable infants who are going to get severe disease can still get it. The population estimates come down to this: accounting for the seroprevalence in different populations and the differential risk across the gestations represented in a birth weight less than 1,500 gram population. CDC estimated that roughly 1.5%, anywhere from 1 to 2% of all very low birth weight infants were at risk to develop severe disease from postnatal CMV infection. So now we'll talk about some outcome studies. What is the impact of these infrequent infections, and should we worry about it? The literature on the impact of postnatal CMV infections has focused for many years on the association with bronchopulmonary dysplasia. There are many smaller studies published in the 20th century. I'm going to focus on 3 larger, more contemporary studies. The first study is a single center study that focused on infants born at less than 1,250 grams. This was done at one of my centers in Boston. It was a nested case cohort study looking at 19 cases of infection in a cohort of 1,080 infants. And it used a regression model adjusted for a variety of predictors of both infection and outcome. And in this single center study, the odds ratio for developing BPD was 4.0. with the 95% confidence interval demonstrated here for an increased risk of BPD associated with postnatal CMV infection. A much larger study was done across in a multi-center data set focusing on babies born under 1,500 grams. This was a case control study using a propensity score to match the cases to controls, matching on 16 different variables associated with the exposure and outcome. And in this study, the authors concluded that there was an increased relative risk of 1.33 for BPD associated with postnatal CMV infection. This same multi-center group went on to do another study in a more contemporary period going up through 2016. In this analysis, which included 273 cases and 273 controls, the propensity score was again used to choose the controls and extended to matching on 17 variables. But the point estimate was pretty much the same, with a relative risk of 1.3 for developing BPD in the setting of postnatal CMV infection. This last study also focused on a number of other outcomes. Specifically, the investigators found an elevated relative risk of 1.8 for a failed hearing screen at NICU discharge associated with postnatal CMV infection, and also found significantly longer NICU stay and a lower weight for age Z-score at discharge associated with postnatal CMV infection. The issue of postnatal CMV and necrotizing enterocolitis has been explored in multiple studies. Multiple studies describe a neck-like illness as an expression of postnatal CMV infection. And there are case reports that document pathologic detection of CMV in resected gastrointestinal specimens in very severe cases of GI illness. The Atlanta group that had done the blood transfusion study reported on almost 600 infants that were assessed for postnatal CMV in a very recent report. This report included 33 infants of these 596 that developed postnatal CMV infection. They reported that necrotizing enterocolitis occurred in 18% of those with CMV compared to 7% of those without CMV for an adjusted cause-specific hazard ratio of 2.8. They also noted that exposure to higher breast milk CMV viral load was associated with a higher risk of necrotizing enterocolitis in this study. The issue of neurodevelopmental outcomes specifically attributed to postnatal CMV infection is complicated by the fact that most infants, as we have seen in this discussion, who develop postnatal CMV are also at relatively high risk of neurodevelopmental impairment on the basis of very low gestational age. And I'm not going to go through all these studies, only to tell you that many people have made the effort. Most of the studies have had a relatively low N of at least under 50 or under 100 infants. The age at which these infants were studied is different throughout them, and the different measures were used. And not surprisingly, there are different findings. 2 studies that I list here found no significant differences attributable to postnatal CMV infection. Other studies demonstrated cognitive delay or evidence of brain changes on MRI attributable to postnatal CMV infection. I would like to highlight one study that was published in Pediatrics in 2018. This was a study of infants born at less than 1,500 grams in the Netherlands in the 21st century. The study had many findings. It was quite rigorously done, but limited by different tests done at different ages, a variety of exclusions, and reasonable loss to follow-up. It did have the advantage of testing all infants at term equivalent age to have a very thorough look at who was CMV infected during their NICU stay. I'd like to focus on 118 infants in this study who were born all at less than 30 weeks gestation and assessed at 6 years of age with a number of appropriate neurodevelopmental studies. Of these infants, 85 were CMV negative and 33 were CMV positive. No differences were found in motor development, but similar to the prior slide, there were impacts on cognitive outcome, with a lower verbal IQ noted among CMV positive children and a trend to a lower total IQ among CMV positive children. There is no evidence of an increased risk of sensorineural hearing loss in this study. So what is the risk benefit to preterm infants? Can we or should we prevent postnatal CMV infection? Well, first, can we lower the risk of CMV transmission? Various efforts have been made to do this. Traditionally, folks had believed that freezing milk would lower the risk of CMV infection, and it's true that freezing does lower the infectious viral load in milk, but it does not eliminate infectivity, and probably for our most vulnerable infants does very little good. Holder pasteurization, heating milk to a high temperature for 30 minutes, is used in the preparation of donor milk, and it does eliminate CMV entirely, but alters the immune properties of milk. A recent publication reported on the use of in situ short-term pasteurization, so holding the milk to a high temperature for a very brief period in a special device. This has been described as significantly lowering the infectivity of milk and is associated with a lack of CMV transmission in a single center study in Germany. There's international practice variation that already exists around this topic. The Austrian Society of Pediatrics does recommend Holder pasteurization of seropositive milk samples for infants born at less than 1,500 grams and less than 32 weeks gestation. The French Food Authority advises pasteurization for infants if they're born under 1,000 grams or under 28 weeks, but only if born to seropositive mothers and only until about 32 weeks corrected gestational age. Many NICUs in Germany pasteurize milk, and it were these German investigators that have developed this device for bedside pasteurization and have demonstrated the clinical utility of using it. The American Academy of Pediatrics has, up until to date, has taken the view that the value of routinely feeding fresh human milk from CMV seropositive mothers and preterm infants overall outweighs the risk of clinical disease, especially because no long-term neurodevelopmental abnormalities have been reported. That statement still stands and reflects the continued uncertainty from the studies that have been published to date over the impact specifically of postnatal CMV infection. I'm not entirely certain how to resolve this, but the totality of the literature would suggest to us that we need to think about postnatal CMV as an opportunistic infection. That is, if we really should move away from a focus on CMV as a disease impacting the entire preterm population, defined as babies born less than 1,500 grams or less than 32 weeks, and really study the impact of CMV on those who are most vulnerable to harm. I would argue the lowest gestational infants, and specifically those who are exposed due to maternal status. If we did that, that would require that we determine maternal status on all infants who are admitted to our NICUs. Taking this type of approach would be akin to looking at the way CMV infection risk is managed in transplant patients, where very focused attention is given to the most vulnerable patients and only if there is evidence that they've been exposed in the course of their care to CMV. I think it's also fair to say that we cannot think of postnatal CMV infection as a linear issue, but as one that is an opportunistic infection, has many complex inputs. And what I mean by that is we know that there are multiple confounders that impact both the exposure and the outcome. We need to account for the vulnerability of the host, for the role of maternal immunity, and for viral factors that impact transmitting versus non-transmitting strains. In that way, we could design studies that would really focus with appropriate precision on how CMV infection is transmitted and how it may create altered immunity, inflammation, mucosal fragility, and tissue damage that may in fact lead to outcomes such as BPD, NEC, and neurodevelopmental impairment. So in conclusion, very low gestation infants are at risk for breast milk-acquired CMV infection when they're born to seropositive mothers. There's no evidence for negative impacts, there is evidence for negative impact on the risk of BPD, NEC, and neurodevelopmental outcomes. But that evidence remains subject to some debate. There are certainly benefits of breast milk feeding, and they have been established in a wide literature. Therefore, the balance, the overall risks of postnatal CMV infection remain somewhat unclear. And I would argue that a definitive multi-center study addressing the relationship of CMV with the risks of BPD, NEC, and neurodevelopment could determine the true risk-benefit balance for our most preterm infants. These are the references that I have used today in this presentation. And again, I thank you for the opportunity to present to you today.
Thank you very much, Karen. Thanks a lot. And this is not a warning, but I'm telling you because other questions from neonatal sepsis and neonatal meningitis is coming to you and Dr. Sajjad, because Dr. Poulin and Dr. Haq is still sleeping, so he recorded that thing. So I have to ask, and of course, Karen did a lot of work in infectious disease. So I would like, Eamon, you can start with Dr. Sajjad and then build up the discussion.
Yeah, thank you for both speakers. Our excellent presentation. Assalamu alaikum, Dr. Sajjad.
Everybody.
My question about the screening protocol that you have for babies who are born to COVID-positive mothers. In our protocol, we start the first screening for the baby at 24 hours, where you mentioned that in your protocol, you do it at delivery or after delivery directly. Do you know anything about like why this is variation? I mean, we were worried about like contamination, not really true, colonization of the babies. So can you comment on the timing of the first COVID test for babies who are born asymptomatic to a COVID-positive mothers?
No, I don't think I mentioned that we should be doing a delivery. The protocol
Okay.
which I mentioned, it was saying either do one at 24 hours and second
Okay.
at 48 hours, or just do one between 24
Okay.
and 48 hours. So I think
Okay,
probably
great.
it's the same as it's yours.
Yeah, okay.
Karen, you have any suggestion about the timing of COVID test? Because we are doing at the time of birth.
In Boston, in Philadelphia, we have been starting at 24 hours and then repeating it 48 and 72 hours if the child remains in the hospital. Of the COVID positive infants that we've identified at Philadelphia Penn Associated Birth Hospitals, I think only one of them was positive at 24 hours. Most of the transmissions we've identified are horizontal after birth, and we identify them at the 48-hour screening.
Okay,
Great.
so next, from the Dr. Richard Collin lecture about the neonatal sepsis, Karen, he showed your publication also. So what is the latest you are doing? Because one question I received just now from the audience that if the baby is asymptomatic, but the CRP or procalcitonin high, what you will do? You will treat the baby, and I need your comment also, Sajjad and Eamon. So Karen.
So we have moved in my centers to not using either the complete blood count, CRP, or procalcitonin as a screen at birth, either for term babies or for preterm babies, to make a decision about empiric antibiotics. In term babies, we do use the sepsis risk calculator models, and in preterm babies, we use the circumstances of preterm delivery. I'm not saying we never use a CRP or a CBC to make a decision. If we do that hours or days after birth. We certainly do it when we're evaluating infants for later onset infection. But there are too many inputs around the time of birth that contribute to abnormal values in the inflammatory markers. Maternal inputs, technicalities of birth, just the natural rise and fall of those markers. And so we have really moved away from using them to make that decision at the time, near the time of birth.
Sure. Dr. Sajjad, what's your experience about that?
Yeah, I mean, we're not using the calculator. We're not yet there to understand and how to practice it. But at the same time, we're not using the CRP or procalcitonin at birth as well. We usually do it 12 hours or 24 hours after birth. But we have to start the antibiotics depends upon the clinical circumstances and the risk of sepsis in a baby.
I think, Dr. Junaid, the most important issue is that, first of all, when you have a diagnosis of chorioamnionitis, the gold standard for chorioamnionitis diagnosis is placental examination or culture. Now, in our settings, I don't know if yours, Sajjad or Dr. Junaid, I know in the US, you send all placenta for pathology when you suspected chorioamnionitis. Now, here, we don't have that luxury. So that's one. Second is that if you have a full-term baby who is asymptomatic and the mother have a suspected chorioamnionitis, we admit the babies to the NICU, which is not really what the protocol called for, because we want to assure the close monitoring of those babies. Those babies should be examined every 30 minutes for first 2 hours. And then 4 hours after that, every 4 hours for 24 hours. And, after that, it will be every 6 hours or more. But if you, we don't do any labs, because as Dr. Karen mentioned, if you have a CRP, there's a lot of things that can cause the CRP to go up, and then you're going to get, abnormal value, and people get nervous and they start antibiotics. So we don't start antibiotics, we don't do lab if the baby clinically well, full term we're talking about. If the baby is symptomatic, of course, you have to start treatment. If the baby is premature, we can do the screening, and then depends on the baby's symptoms. If he's asymptomatic, you can wait. If he's symptomatic, you have to treat.
Karen, there's a question for you that again, the practice is different in Middle East than in USA. So the use of or the treatment of CMV ganciclovir or ganciclovir for the 6 weeks or month, is there what is the benefit? Is I mean only to protect the hearing, or there are much more to that? I mean, they just want you to elaborate a little bit more because it's a long treatment, and many of the hospitals they don't have even the ganciclovir, so they have to admit for 6 weeks ganciclovir.
Yeah, you'll notice that I didn't go over any literature around the benefit of ganciclovir because there is none. Ganciclovir in valganciclovir, which is now orally available and actually very bioavailable, is not labeled for use in newborns for this indication, and there's no efficacy data. There's case reports that when infants have severe sepsis-like syndrome, people try it. And I did note the one study that looked at the reduction in viremia associated with starting it. It is a fairly, it has a lot of side effects. There's a lot of hematologic depression, suppression that comes with it. And although there is an evidence base for hearing preservation in congenital CMV, there's really no organized evidence around whether it should be used in postnatal CMV. That's not to say it shouldn't be. It's just how to dose it, how long to give it, and what your endpoint is. So what people do is if a child, develops what they think is an acute CMV pneumonitis, they administer it with the hope that it will be helpful. And theoretically, if it decreases the viral burden and viral replication, it should decrease the associated inflammatory response, which is primarily what's damaging the preterm infants. But it's an area that needs serious study. And there's a lot, at least in the United States, if you ask 10 infectious disease experts, you'll get 10 different opinions about how to use it in this setting.
Sure. Dr. Sajjad, there's a question about, you mentioned in your presentation about that one of the ways the baby can get COVID is the breast milk. So what is your practice that if the mother is positive and the baby is not positive, you don't allow the breastfeeding? I missed that part.
Breastfeeding is allowed. Even if the mother is positive, still the breastfeeding is allowed. And it has not been proven that the breast milk actually transmits the virus. But it has been proven that the breast milk actually transmits the antibodies, which are protective against COVID. So mother should breastfeed. If not directly, she can express the breast milk till she is negative and non-infective. Even during the active phase, she can have a face mask, and with all the precautions, she can and she should breastfeed.
There's one question about MISC in neonates because I don't know if Eamon saw of any case because we are designated non-COVID hospitals, so that's why we are not having those sick babies. So can you elaborate more? People want to know that you describe the signs and symptoms. So how early you can diagnose? Only on the basis of signs and symptoms, or is there any specific test of that particular syndrome?
Is it for me or for I?
Yeah, for you.
Yeah, actually, Miss N is a clinical syndrome, but then we have to have some kind of biochemical markers. And there are a number which have been mentioned in the literature, but we have limitations to which we can do. For example, we cannot do the interleukins and many other things, but we can easily do the ferritin levels, LDH levels, CRP. So that's what we are doing. And the MOH criteria actually mentions some of these. What should be the level at the time of admission or in follow-up, and how rapidly these should be rising. And this is associated with the clinical condition of the baby, is in hypoxic respiratory failure, in high frequency oscillation and nitric oxide, and at the same time circulatory failure, leading a lot of inotropes. So of course he is very sick, and it looks like he has got this N. Then we also look at the multi-organ failure,
Mm.
how they are doing with respect to their kidney perfusion and urine output, what is the level of bone marrow reaction, and platelet count, and WC count, lymphocyte count. And all these things have to put together to say that whether the baby has MIS-N or not. But these are new diseases, new syndrome, and that's why we want to share the experience. And I'm sure many people have much better experience than us, and we can learn from each other. And then probably the time is coming when the people will come with the consensus statements about what is the definition and how it should be treated. As I mentioned, HRCT is a very good tool to diagnose the pneumonia in patients with COVID-19. And there is a criteria for severity scoring in adults, a criteria with 40 and a criteria with 25 items. But in pediatrics and neonates, still we don't have the consensus criteria. Probably this needs to come in the coming days.
So there's another question about neonatal meningitis. So I will start with Karen. If you can answer, then I will, Ayman and Satya can also comment. About the lumbar puncture, you get a baby, you suspect infection, and then you suspect that it might be LP. So you did the LP, you have to repeat it if the LP become positive. Or what are the criteria to do the lumbar puncture in those babies? Karen, if you can comment on that.
No, the decision to LP in early onset infection is a hard one, because very often the infants that you are most concerned about are the most ill. And there's also controversy around the extremely low birth weight baby, especially if you're using IVH prevention protocol, where you're trying to keep the child midline and undisturbed. I think in general, the American Academy of Pediatrics guidance suggests that if you have a very high suspicion and you have enough clinical stability, you should do the LP prior to initiating antibiotics, but you shouldn't delay the initiation to get the LP done. If you have done it and identified an organism, especially a high-risk organism such as Group B strep or E. coli, it is recommended that you do a repeat LP to ensure sterility and to ensure that the inflammatory response is declining. Both of those organisms can create complicated CNS infections, such as epidural abscess, for example, and GBS. These are not common, but the recommendation remains to demonstrate sterility of the CSF in the same sense that we do a repeat blood culture to demonstrate that you've cleared bacteremia.
Sorry. So in our unit, what we do, as Dr. Karen mentioned, that we're really very careful about doing LP in the extremely low birth weight infants, especially babies like under 28 weeks, in the first 72 hours. So even if we're suspecting meningitis in the first 72 hours, we start meningitic coverage and then we defer the LP until 72 hours. And there's a study showed that there's increased risk of IVH grade 3 and 4 if you do the LP within 72 hours, if the extremely low birth weight infants. So we cover, we do wide spectrum coverage for meningitis if we have a high suspicion. And then we do the LP after the 72 hours. That's our practice. Now, to repeat or not to repeat, if you have a full term and you have a GBS, then, the recommendation is not, if it's a normal course, you may consider to do LP, but you don't have to. But any other organisms, gram negatives or anything more than GBS, you need to prove sterility of CSF. Or if you have any complication, if you have a persistent fever or you're suspecting any brain abscess or ventriculitis, then you have to repeat the LP.
Okay, there's one interesting question by the audience. They mentioned about one publication from India, and they said in the cases of very severe sepsis, they do exchange transfusion, and it seemed to help according to this paper. I never heard of it, but they said, what is our panel's take on this and guidance? So if any one of you can comment on that.
I can't say I've ever done it. It is reported in older literature. it's going to be something that is probably only technically reasonable in a term infant. I don't think it's an established modality.
It's mentioned in some references that exchange transfusion can be treatment for severe sepsis, but then you have to worry about the risk of complication during the exchange transfusion. And if you have a good antibiotics available to you, then I don't think anybody, as Dr. Karen mentioned, have done exchange transfusion in severe sepsis. I know Dr. Sajjad.
Yeah, Dr. Sajjad,
So do you find it useful?
Yeah. What?
Yeah, you have found it useful because we have never done it for.
No, we have not. We've never done it. I mean, it's mentioned in the textbook that you can have exchange transfusion.
Yeah, we have never done it as well.
Yeah. I have a question, Dr. Karen, actually, about CMV, acquired CMV. If you have extremely low birth weight infant and you have a donor milk, the parents coming with a donor milk, what do you do with that milk before you give to extremely low birth weight infant? Do you test it? Do you do PCR or you test the mother? I don't know if it's a big issue in the US, but it's very common here in our area. And maybe Dr. Sajjad can comment on this also.
In the United States, we do have the advantage of pretty widely available donor milk from donor milk banks, and they do pasteurize the milk.
Yeah.
What you're talking about, we tend to refer to as informal milk exchange.
Correct. Yeah.
And it varies from center to center, whether they test the milk or whether they ask the family if the donor is willing to have CMV testing. Interestingly, at Penn centers, we ask the family to sign an informed consent document that really lays out the risks of informal milk sharing, including the CMV issue. So it's a little bit difficult because families who want to do that generally feel very strongly about it, and we do not like to stop families from making decisions about their infants, but we do counsel them in a both direct way, and then we sort of legally document the risks that they're assuming with informal milk sharing.
When you freeze the milk, actually, you decrease the little bit of the CMV.
Yeah, you do. You decrease the CMV titer, and I think as Dr. Lanzieri's study showed, you can decrease the absolute incidence of identifying postnatally acquired CMV, especially if you're doing a surveillance study and you're really picking up all the asymptomatic cases. But for the sort of 500-gram, 23-week infant who's most vulnerable to getting symptomatic CMV, that degree of decreased infectivity doesn't seem to make that much difference because it's just an extremely vulnerable host.
What do you think, Dr. Sajjad? What's the practice in Saudi? I'm sure you have those.
We don't have the breast milk banks where we can get the milk from various sources, but we do have facility where individual mothers themselves, they bring their milk and we do store that and we do freeze that as well. And as long as the mother is healthy and has no clinical problems, we just feed that milk without any.
Do you get him to sign a consent when you have an informal milk sharing? That's Dr. Karen. We do the consent exactly the same way that Dr. Karen mentioned.
We don't share much of the milk.
Okay.
So we don't.
But sometimes you get it like actually, you don't ask, they don't tell you. But if you ask, they tell you.
Okay, so another question on my WhatsApp, that most of us, when we start antibiotic for 48 hours, the culture negative, we stop antibiotics. They are asking that, what about 36 hours to stop antibiotics? And Karen, start and then everybody.
My research group has really done a lot of work on this recently, looking at time to positivity of blood culture. Mm-hmm. And what we say to folks is that if you do have good local data and you understand the time to positivity results from your laboratory, it's not unreasonable to use more of the 36-hour cutoff. We did a big study with the Kaiser Permanente group in California that I collaborate with, purposely to take different centers with different policies and different blood culture machines to try to look at whether a time to positivity based process would be reasonable. And 36 hours really identifies the vast majority of early onset pathogens. We're preparing a manuscript now around late onset sepsis, and it does get more complicated. The pathogens are different, and there's a lot more pre-treatment going on in that setting, and so it's less clear. It's certainly clear that if you work at a center where you get a blood culture and you send it right, usually downstairs to your lab in the basement, that is different than if you're a center that sends blood cultures to an off-site facility, because that, what we call pre-analytic time, can impact the time to positivity as well. I think also there's increasing data around how long some of these antibiotics endure in our tiny babies. And we probably underestimate just how long a 1,000-gram baby has an effective antibiotic in their bloodstream. I'm hoping that over time we'll have better pharmacokinetic data that will also inform that decision.
We look at our local data actually in our hospital, and we publish this in the, for the time for positivity for early onset sepsis. We found a vast majority of the cultures growing within 24 hours, with one exception, which is staph epi. So if you don't have a high, strong, suspicion of staph epi or early onset sepsis is not going to be on the top of your list, it's reasonable. I think the most important thing here is the volume of blood that you send to the lab. If you have a standardized, guidelines for doing at least 1 ml of blood, don't do like a few drops of blood, then time positivity will become very important. And I think within 24 hours, the vast majority will be positive. It's going to be positive.
Yeah, we actually do the same, particularly in early onset sepsis. We tend to stop the antibiotics between 36 and 48 hours, particularly if the baby is clinically well and all other parameters like blood counts and CRPs and everything is normal. So we tend to stop it as quickly as we can, usually between 36 and 48 hours.
Thanks a lot because of the timing. Dr. Joseph, who is already logged in, and my friend Dr. Sridhar. So we have to start another session because Karen, Dr. Sajjad, I have few more questions I will email to you definitely. And at your free time, please answer that. There are a lot of, because you are covering neonatal sepsis, neonatal meningitis, and CMV and COVID. So I will do that. So thanks a lot, both of you, and Dr. Ayman to
And thank you very much to both of you and the audience as well.
Thanks a lot.